We are live.
Thank you. So, good evening, friends. And let me wish all India Ophthalmological Society members and all the audiences a belated Happy Independence Day to all. Though not a very happy moment at this point for our country, we are definitely going through some bad times, and we express our solidarity and our pains with the family of a young girl who lost her life about a week back in Kolkata. The All India Ophthalmological Society expresses the solidarity with the whole members of all the doctors of our country, and we pay a 1 minute homage to the departed soul by maintaining a 1 minute silence, and then we'll initiate.
Hello. Unmute myself, right?
Om Shanti Om. So, friends, here we are into the webinar on behalf of All India Ophthalmological Society and Academic and Research Committee. Basically, this webinar is designed and labeled as Trauma for All. We began this series of a subspecialty for comprehensive ophthalmologist in the month of January. The aim was that there is a lot of changes which has happened in the understanding of various subspecialties as well as in the therapeutic modalities by which we treat our today's patient. And there is a sea of revolution in all this understanding. So it was thought prudent that let us make aware all our comprehensive ophthalmologists who are practicing in the periphery with the recent concepts and also with the topics which are of day-to-day clinical practice in their day-to-day clinical practices, because we as a subspecialty societies are quite small in number, and we cannot reach out to the 1.5 billion population which our country has. And these are the first line of doctors who come across. And with this initiative, with this thought process, this particular initiative of having a subspecialty webinars for our comprehensive ophthalmologists was thought, and the series was started in January 2024. So this is our webinar today in association with Ocular Trauma Society of India. I'm really thankful to Professor Ashok Grover sir, Dr. Mehul, for kindly consenting without any reservations to be a part and associate with Academic and Research Committee for this particular webinar to create awareness about this topic amongst all our comprehensive ophthalmologists. The other thing which I shared with Dr. Grover sir, to which he readily agreed, was as an Academic and Research Committee, we thought that we would be giving opportunities to younger pool of younger generation of ophthalmologists who would be coming as a speaker, especially for speakers less than 50 years. The aim of our society this year we have thought of is to groom young talents and to give them this podium. And we can, if we can groom and nurture such young talents and all our senior people to be the mentors, we will be doing a great job for the society and will create a great good pool of leaders. With this intention, today's most of the speakers you will note is younger generation, newer speakers. Many times they are for the first speakers. And so I request all the senior people to be a mentor and guide and complement with the topics, whatever are left out or you feel necessary to think. The other thing which is peculiar about this particular thing is about the Saransh. Saransh is an article which we introduced in the month of January 2024. Most of the people who are comprehensive ophthalmologists do not have an access to all the journals of subspecialty into their practices. And neither do they have time or an inclination to go through all the articles which have made an impact into their day-to-day, into our understanding of this newer disease process, into the disease processes and their therapeutic modalities. So we request usually one of the senior persons from an institution to give us on a platter just the gist of the articles, what have changed the way we look at a disease and the treatment modalities in a very short thing. It will not be a very detailed article, and it is very well taken. And so this today's Saransh would be presented by nothing no other than Dr. Rajiv Raman, who himself is a big researcher from Shankar Netralaya. So without much ado, now I would request President OTSI, Dr. Ashok Grover sir, to carry forward the further proceedings with these feelings. Thank you once more.
Thank you, Prashant. It is a privilege to have this forum, which is designed to give a knowledge which is useful to a general ophthalmologist, to postgraduates, and to specialists alike. And this format that you have designed on behalf of the Academic and Research Committee is a wonderful design, as it conveys the information in a manner which is easily understood and easily assimilated by everyone. We share the anguish of the medical profession today for the very unfortunate incident that has happened in Kolkata, and it is a wake-up call for all the medical professionals. I'm sure with our efforts, we'll bring sacrifice that has been made or the sacrifice that has happened to be able to bring some solution to improving things, both for residents, for women, and for medical professionals as well. With that, of course, I would first like to thank all the people that have joined in as experts, particularly thankful to Dr. Prem Subramaniam from USA, to Annette Hoskins, who is our keynote speaker, to Dr. Rajiv Raman, who will be giving the Saransh, and all the speakers, many of them seasoned, many of them young, as Prashant has pointed out. And as Dr. Prashant pointed out, the Academic Research Committee has progressed by leaps and bounds. As one of those who initiated the activities of chairman of ARC from 1996 to 2002, looks like an ancient time, the activities of ARC took seed, and it's nice to see it flower into a wonderful tree which is bearing such a lot of fruit. And I would like to compliment Prashant for all that is being done. With that, I will hand over to Dr. Shakeen Singh to begin with the program details. I would only add that ocular trauma is such a significant problem, such a significant cause of mortality and morbidity, that it is important to carry it forward as a science so that the fruits of best management reach everybody. And for that, all tertiary care institutions need to make a lot of effort. And this particular webinar is a step forward in our efforts to carry the knowledge of ocular trauma to everyone, including primary ophthalmologists, who are the front line for managing ocular trauma. Thank you, Prashant, and over to Dr. Shakeen Singh for carrying things forward.
You're muted, sir. Shakeen, sir. Shakeen bhai. Dr. Shakeen, you're muted.
If Shakeen is not able to join,
I see Dr. Purendra is also there. Dr. Purendra Bhasin, sir. Okay. I think till Dr. Shakeen takes over, let's have with the move ahead with the first.
With the keynote, yeah, we can request Annette to go ahead with the keynote. We can begin with the keynote.
Yeah, Dr. Annette, please. You can share your presentation and then we can formally introduce the expert panel following that.
Okay, perfect.
Before Annette starts, may I say that Annette can be credited with a lot of the activity in the global scene in ocular trauma that has happened. She's been a wonderful researcher who's brought a new dynamism to the field of ophthalmic trauma. She's done a lot of pioneering work and brought in a lot of new facts and new methodologies into ophthalmic trauma. So welcome Annette Hoskins. She's from Australia, and it is wonderful to have her as our keynote speaker.
Thank you so much, Ashok. It's a pleasure to be with you, and congratulations on putting together such a wonderful forum. I think this is a great initiative and certainly something that could be replicated and learnt from in many places around the world where trauma is not well recognized as a subspecialty yet. So these education forums are particularly important. So I'm hoping you can see my screen okay. You'll let me know if you can't hear me. And these are my disclosures. Thanks, Ashok. These are my disclosures just for your information. So I guess I'll just start, and this is probably something that is already well known by all of us, but eye injuries are a rare but true emergency. And without large, structured and quality data sets, we can't really inform management strategies and prevention strategies. So one of the things we said about working on, and so I've worked with many of the experts on this call, as well as others who are not with us today, including Rupesh Agarwal from Singapore. And one of the things that we identified initially was that there was really, even though there was a common language, we really recognized that common language was critical to the area of ocular trauma and all of the things we were looking at. And because that hadn't been reviewed for some years, we felt that this was a good starting point. So what I want to share with you today is a little bit of what we've done relating to ocular trauma and the language that's used. And I'll share with you toward the end some scorecards that will help you to define the sorts of eye injuries that people have, because the ability to communicate on this, both from a management and prevention perspective, is particularly critical. So there's been many, in particular, there's been one key area of work that was conducted by Ferenc Kuhn, and we really see that as the starting point for terminology relating to ophthalmic trauma. So when we looked at that, and we wanted to review that with respect to what had happened in the past 25 years since its inception, to try and identify whether there are any specific gaps in the terminology or the classification. And part of the work that we looked at was with respect to eye gates, which we have many colleagues from India who participate in eye gates. And it's been a really fantastic tool to help us understand when and where eye injuries happen. So I'm going to talk about, touch on a little of those 3 points really, and just a little bit about where next in terms of ophthalmic trauma. So I mentioned Ferenc Kuhn. So any of you have read any of the literature relating to ocular trauma or ophthalmic trauma would be well aware of his work. And basically, before the article that he published in 1995 was published, there was really no systematic way of looking at definitions and terms with respect to ocular terminology. And so we use this as a really important starting point to look at what is still valid and what else we can look at in the future. And I will just make a point. So ocular trauma is often a term that's used. Ophthalmic trauma is the other term. And we feel in the discussions that we now undertake, ophthalmic trauma is a more inclusive term. So ocular indicates the eye or the globe. Ophthalmic is the globe and the adnexa. So we feel like it's important to ensure that all of that information is captured, not just trauma to the globe. And so that was one of the key things that we looked at, as well as many others. But just to explain, I probably sometimes use the term ocular trauma and sometimes ophthalmic, but ophthalmic is considered more encompassing. So when Ferenc wrote the article in 95, he said it can be reasonably expected that this system will ultimately become an international language for ocular trauma. And I think it's safe to say that after that article was published, it really did become a very widely cited, very widely known terminology. And it's not just important in the literature and the research, but also in what we do every day when we talk about eye injuries. And I've just given a screenshot there from the paper. It talks about penetrating injuries, and this was one of the key things when looking at eye injuries. There are a number of things that were quite confusing. So when people reference or name a certain injury, it's quite important that we're all talking about the same thing. So a question about penetrating injuries, whether whether that how that's defined. So in his paper, Ferenc went on to provide a system of classifying all of these terms, and that's been very helpful in practice and in research, as I said. So, as I said, the ocular trauma score and BETS classification really became a great foundation. I'm going to give you toward the end of the talk some references, both to Ferenc's paper, but also to something we published with a scorecard that helps delineate all this information. But this slide really just summarizes the broad classification of closed and open globe injury at the top, and then coming from that, off that, the types of closed globe injury being contusion, lamellar laceration, open globe injuries on the right, rupture, penetrating, perforating injuries, as you can see. So, as I said, we took the terminology created in BET, and we wanted to identify whether this was the most appropriate moving forward, whether there are any gaps, whether it was still valid 25 years on. We undertook a Delphi study involving a large number of clinicians who are recognized specialists in the field, and we wanted to first look at a broad range of terms which came out of BET, and then drill down to get extra granularity around the different additional terms that might be appropriate. So this just quotes from the paper there, the different terms and how accepted they were by the group of experts. And you can see we largely got consensus on all of the fundamental terms relating to BET. So this is the paper that we published, and I've included the QR code there so you can pull up that paper. And as I said, we felt like this was a really good fundamental paper to help us understand and move forward in the area of ophthalmic trauma. And it's really helped inform a lot of our research going forward. So iGates, which is the trauma registry that I referred to earlier, incorporates all of our findings from this survey, and we use that now to collect data. It's an ongoing retrospective and prospective registry to look at eye and adnexal injuries. So in addition to what was already existing in the BETS classification, we identified some other fundamental additional things that should be classified. So firstly, lens injury in the center there, and then secondly, injury to the adnexa. And so these weren't originally included in the classification, and the intention at the very beginning, 25 years ago when BETS was written, was to try and have a very simple classification. Again, it achieved that well, but it's now recognized that lens injury and adnexal injury can have some very severe consequences in terms of functional outcomes for the patient. So we considered these important to add. So that's why I've noted BETS++. So trying to add additional terms, and of course, with any terminology or with any research, we've really got to find the right balance between collecting enough and too much data. And if we try to collect too much data, the database becomes unwieldy. It doesn't get used and it's not really performing to its purpose. So we're really very conscious of that when looking at what additional terms to add, but certainly looking at the literature and in speaking with the experts, we considered these two additional areas, lens injury and adnexal injury, very important additions to BET. So the other thing we looked at was to try and drill down to give us more granularity on the trauma zone. So looking not just at zone 1 injuries, but looking at injuries to the central cornea and considering those that are the most, in terms of prognostication, most likely to result in a poor visual outcome. Also looking at zone 2, looking at those injuries that are outside the limbus to 5 millimeters posterior to the limbus. When we're looking at zone 3, those in the extremities of zone 3 that we've called zone 3A, and zone 3B, which is beyond that, 8 millimeters posterior to the limbus. So trying to look at what additional things, so if we're looking at an injury, trying to identify with more accuracy where the injuries are happening, and then using that to identify and prognosticate about what the worst possible outcomes are from injuries. And this, of course, all helps us when counselling and talking with the patients to help them understand what the likely outcomes are going to be. So other than looking at the anatomical classification, the other thing that we really thought was valuable to add to any classification relating to trauma to the eye was the mechanism of injury. So many of you would be familiar with terms like sharp and blunt, intraocular foreign body, but we wanted to add mixed injury because these are the sorts of injuries that combine a very high energy, possibly a sharp and a blunt injury, and they end up with the worst possible outcomes. These are often caused by blast injuries, fireworks. These are the sorts of things that give us a mixed injury. So when thinking about how you classify it, understanding that some injuries are not just sharp or blunt, but they may be a mixed injury as well. And the other two, taking into account animal and human bites, which we're all aware come up in the literature. They're perhaps not as frequent as some of the other types of injuries, but certainly quite significant in terms of the outcomes and the prognosis associated with those. And lastly, on the right, chemical and thermal burns. So with these 6 mechanisms of injury, as well as the anatomical classification that we have, we feel like we've got an excellent tool for describing and classifying the injuries. I mentioned the eye gates registry before, and just to give you an idea of what this looks like for those of you that haven't seen it, this is an online registry. It can be offline as well, depending on ethics for your institution. It allows you to collect data and collect information relating to the ocular trauma score. So once you have the information there, it feeds it through, and then outcome data. And we're using all of this to continue to research this area and collect data, both on baseline visits, but also follow-up visits to understand the outcomes of these injuries. So you can see there just an overview of what the registry looks like if you go online. I would certainly encourage any of you who are interested in eye injuries or ophthalmic trauma, if you're interested at all in participating in eye gates, to please be in touch. We have an amazing cohort of collaborators from India who are continuing to collect data, and this is all incredibly valuable in helping us understand the outcomes and the prevention strategies that we might be able to use. So again, just highlighting about mechanism, I said before, in terms of the data that we have from eye gates, you can see that you get a fairly even distribution of sharp and blunt, a very small number of mixed injuries. But what is important about these, again, is that these have the worst possible outcomes. So we're monitoring and tracking these. In particular, burns and bites are relatively but important number. Just a comment about the burns, often with chemical burns, they are bilateral, which of course is incredibly devastating for the patient. Losing one eye is already catastrophic, but losing both has, untold effect on the patient. So in terms of where we go next, we're looking to continue to use eye gates to improve prognostication. We may look at a revision of ocular trauma score or OTS, again, to help prognosticate about these injuries. We're always looking to improve our methods of data collection using artificial intelligence where possible to reduce the burden of collecting that data and ultimately provide quicker access to the data to improve the interventions. And of course, with all of our work, the aim that we have is to reduce avoidable vision loss from ophthalmic trauma. I think we all share the same interest and passion in ensuring that we continue to reduce these eye injuries. So the scorecard that I mentioned is featured in the paper that I gave the QR code to, but this just gives you a quick snapshot. If you're working in the area of ophthalmic trauma or eye injuries, it's a really quick method of you being able to understand what sort of injury you have and communicate it with other people. And we're very happy for this to be used within your hospitals or in other settings that this might be useful. It will enable a very quick way of communicating what's going on with the patient. So just a quick thank you again. We have many collaborators in India. I don't want to mention the names because there are too many. I would fear to miss them. But of course, we have many of the ophthalmic trauma societies, including the Indian Ophthalmic Trauma Society, who's an amazing collaborator and working with us on all of the eye gate studies. So thank you so much for your time, and I'm not sure if there'll be time for questions at the end, but of course, happy to be in touch with anybody that has any questions.
Thank you. Thank you, Dr. Annette, for wonderfully highlighting the importance of this classification and the eye gates. Dr. Purendra, please.
It was really wonderful that for the opening remarks which has been given by Dr. Annette and highlighting the importance of classification, classifying, and the zone of injury and type of injury, and the role of studying these and then analyzing it. And eye gates from Rupesh and Annette, they have done great job in this direction and updated the classification which has been given by Ferenc Kuhn, and this is going to take us to next level by updating us. And if we classify according to eye gates, I will encourage everyone who is attending this to use this eye gates platform which they have developed, and it is a wonderful platform. Thank you for giving us an overview of ophthalmic trauma. I think we should take questions later on, if any, from anyone, and we should begin with our the talks from our speakers, and our panelists are also there. All of them have joined. Thank you, Annette. So next,
my pleasure.
Yes, Dr. Purendra, you can welcome all the expert panel because of some internet problem. That time we couldn't.
At that time. So we have
Dr. Prem Subramaniam, who has consented to be with us.
Yeah,
Please
please
go
go
ahead,
ahead.
Dr.
Prashant, please go. You do it.
नहीं, आप ही को करना है. You are the vice president. Please speak.
Okay. So with Prem, I think we are really very delighted and privileged that at this hour at your in your country you have joined us and working with you will be the one who will give us the insight on the optic nerve and neuropathies due to trauma. And welcome, Dr. Prem. Then myself and we have a wonderful surgeon from Delhi, Dr. Sanjeev Mohan, my dear friend. He is a beautiful surgeon anterior segment, and he is working with Ocular Trauma Society of India for last 25 years since the time we have begun. And we have Dr. R.P. Maurya with us, who is an orbit and oculoplasty surgeon from Varanasi, BHU, and Dr. Jayant Kumar Das from Assam, Guwahati, Dr. Shreya Shah, if she is there, and Dr. Sushmita Shah. Welcome, Dr. Sushmita, to this to be the part of this expert panel. And we have another great retina surgeon, Dr. Vivek Dave from Ali Prasad, Hyderabad. Welcome, Dr. Vivek. He is a phenomenal surgeon, and his work in retina and ophthalmic trauma and retinal pathologies has given a lot of insight and improvement in the management, and especially in the endophthalmitis part of the retina management. Then Dr. Preeti Uday, Dr. Mayuri Khamar, Dr. Vaishali Vasavada, and Dr. Deventuli, Dr. Murli, and Dr. Tarjani Dave. So I welcome you all. You all are Dr. Rajiv Raman, and you all are expert of your field. And Dr. Devdutt Thomas also I am able to see here. So you are expert in your field, and you will be giving your expert comments in between. And before we begin, Dr. Prashant, shall we start?
Yeah, Dr. Purendra, you have to carry forward the whole proceedings now. You can take help of Sanjeev as well.
President is also with us, Dr. Ashok Grover. So, Dr. Bharti Mehta, yes. Are you in?
Purendra, you carry the activity forward.
Okay, sir. So, Dr. Bharti Mehta is the presenter, no?
Yeah. Dr. Bharti, are you there with us?
Dr. Bharat Mehta.
Dr. Bharat Mehta.
Yeah. Dr. Bharat, are you there?
Please share your screen.
Is he there?
Sunil ji? Sunil ji?
Sir.
Hello?
Yes, sir. Yes, sir.
भरत जी नहीं है क्या? आए थे ना? Okay, let's move on to the next.
You can go on to the next speaker.
Yeah.
Dr. Shalin Shah. Yeah, she is there. So
yeah. Dr. Shalin, please share your presentation.
Welcome, and please share your presentation.
Dr. Shalin, yeah, thanks.
Yeah, is my presentation visible?
All good, doctor. Yes. Please start.
Yes. So we'll be discussing about complex traumas, complex orbital fractures, and taming the beast. So we have a lot of varieties of orbital fractures. We have blowout fractures, blowing fractures, rim fractures, zygomatic-maxillary complex fractures. And then we have a combination of all of them, which are the comminuted fractures. I share two cases of comminuted orbital fractures, which have been operated recently. So our first case is a 39-year-old male patient who had a history of trauma 4 months back and presented with diplopia and deviation of the right eyeball since then. We characteristically notice a retinophthalmos elevation deficit. On imaging, we note that there is a fracture of the lateral wall involving the frontozygomatic suture line. There is a fracture of the floor of the orbit with entrapment of the fat and probably the inferior rectus. And there is a fracture of the zygomatic arch. On the 3D reconstruction, we can beautifully see that the zygomatic arch has been comminuted and there is a displaced fracture fragment inferiorly. However, the zygomatic maxillary buttress is still intact. And hence the patient did not have any complaints while chewing. So how do we plan the fracture? Okay, so my video is not playing. We'll go ahead with the explanation. So here, as we can see in the first image, there is on exposing the bony orbit, lower inferior bony orbit, we can see the comminuted fracture with the displaced fracture fragment here in the first image. In the second image, the fracture fragment has been repositioned into the correct place. That is the fracture prior to repair, the fracture fragment is in the correct position. In the third image, the plate has been put into the zygomatic arch. And this was the follow-up of the patient. Actually, I had the whole surgical video of this case where I was showing repair of the floor lateral wall. Okay, so here we can see that post-surgery, the patient has a resolved squint. The globe which was down and in has now come into the ortho position. Actually, this has been operated just last week, so I don't have a follow-up with reduced ecchymosis. Our next case was a 24-year-old male patient with history of road traffic accident 15 days back when he presented to us with enophthalmos and deviation of the globe. And the pupillary reactions were lost. The vision was hand movements. The retina was fine. As we can see in the imaging, there is a fracture of the medial wall of the orbit with the medial rectus going into the ethmoid sinus, and there is a fracture of the floor of the orbit with the inferior rectus hanging midway into the maxillary sinus. As we can see in the 3D reconstruction, there is a huge fracture involving the floor and the medial wall of the orbit. Okay. So here we can see a fracture involving the floor and the medial wall of the orbit as shown on the demo skull. And this was repaired using a titanium mesh, medium sized. We can actually, yeah, so a medium sized titanium mesh was used to cover the floor fracture and the inferior part of the medial wall fracture. The lateral part of the mesh was trimmed and removed as needed, and the fracture was plated for an optimal outcome. The upper part of the medial wall fracture was left untouched since there was no entrapment in that area. So this is the pre-op and the post-op images. Here we can see an intact fracture on the 3D reconstruction, whereas here we can see a plated fracture, and the patient had significant correction of enophthalmos with correction of the superior sulcus deformity. Thanks.
Thank you, Dr. Shalin. It was a wonderful presentation. And may I request Dr. Dr. Hardik Khurana to discuss on this? Dr. Hardik?
I think all the orbit people can join in the discussion.
Yeah.
Let's move case by case.
Yeah, so I think I can put in a couple of points for these cases.
Yeah, please.
Shalin has presented beautifully, and he has reinforced the principles of orbital reconstruction very well. Because always when we reconstruct the orbit, we do the rim first and then the floor or the walls. So that is what was done in the first case. The zygoma was fixed first, which will fix the rim in its normal position. And then he has put a mesh for the floor. The only few tips that I would like to add for that case is, if you see in the post-op period also, the patient has some amount of enophthalmos. So probably the floor, we need to see the post-op CT scans. The floor implant should rest on the posterior ledge of stable bone behind the fracture. And also the curvatures of the walls of the orbit should be reconstructed. Because usually the floor is S-shaped, and that convexity on the posterior side, if that is recreated well, then you don't have a residual enophthalmos. So probably that can be stressed upon in other cases. Now, the second case, when we see, if you see the 3D CT scan, there was a naso-orbito-ethmoid fracture also. Probably that fracture could have been fixed first, so that the medial side of your orbital rim would have come to a normal position. And then probably we could have done the floor mesh. Now, the kind of floor mesh that we have used here, maybe you can check.
Please mute
Please mute
others.
yourself.
Please.
Request everyone to mute, but for the speakers.
And for the second case, I would say that do the naso-orbito-ethmoid fracture first, get your rim in place. And then for the floor implant, try to use a 3D implant so that you can recreate the curvatures of the wall. Again, there is a residual enophthalmos in that case. But it is beautifully managed, and I congratulate you for that. Thank you.
Thank you, ma'am.
Thank you.
Dr. Tarjini can guide further.
Yeah, Tarjini can.
Just I want to say few points regarding in such cases. Sometimes it may be bilateral also. In road traffic accident, most of the time it may be bilateral. So we can discuss with our anesthesiologist first on the table. So during the intubation, sometimes they may forget to pack around the nose. That is very important. So always full packing around the tube, or if required, if it is a multiple fracture, both sides fractures, and especially medial wall fracture, big fractures, there is a chances of bleeding. In such scenario, tracheostomy should be performed before going. Generally, we ophthalmologists are not so much tuned, so there may be some issues in some cases. But if we do a tracheostomy first, then it will be very, very in a safe mode in case of trauma cases, especially if they're complex trauma. But this case was nicely managed because it's only that medial and inferior wall. She rightly mentioned we can just align the rim first, then only we can go one by one.
I have a question.
Tarjini, would you like to add something?
Yeah, just a couple of points to just complete the discussion that already Preeti and Dr. J.K. Das have beautifully added to. When you have a zygoma fracture, it's a good idea to ask for the patient's mouth opening and check that they are able to open the mouth or not. That also helps your anesthetist in figuring out whether they're going to be able to intubate or they're going to need some fiber optic guidance to intubate. So that's from the examination perspective. From the management perspective, we often come across cases which involve multiple specialties, and because this is a wider audience, just wanted to tell everyone that an open globe takes precedence, everything related to vision takes precedence, and a fracture can always satisfactorily be treated at a little later date as well. Although outcomes of fracture repairs are very good when you operate immediately, but vision would take precedence and an open globe would take precedence before any of these. The final point was that, yes, I totally agree with Preeti that a pre-contoured titanium 3D mesh would help you get better coverage of the floor and the medial wall and help you cover the fracture completely. The commonest complication you see following fracture repair is residual enophthalmos. One, because of fracture, two, because of soft tissue and fat injury that you really can't replace for. Therefore, using adequate coverage with a 3D pre-contoured titanium plate would be the standard of care at this point of time. Titanium is very sharp, and during insertion, you might have lacerations occur in the eyelid. A good swinging eyelid approach to relax the lower eyelid completely would help facilitate plate placement. Those would be the few points from my side. Thank you so much.
I have a question, sir.
Yes, Sanjeev.
Please.
A question to Preeti. Preeti, you said about the first case, if there could be an ophthalmos post-operatively, yes, we have seen it. What is the importance of this basic test of force duction test after the surgery? Can it tell us that whether the patient is likely to have the an ophthalmos post-operatively? That's a very basic test, but that is what we have learned and we have practiced it initially. And especially when I used to work with Dr. Grover, so we used to do it quite regularly.
Yes, hi, Sanjeev. It
Hi.
is absolutely essential for us to do the force duction test at the beginning of surgery. And then once we reduce the fracture and release all the prolapse contents, again, we do an FDT to make sure that all the release is complete. And also after you put the implant, you want to make sure that there is no soft tissue entrapment in the implant. So again, you repeat an FDT. The FDTs are extremely fast in all cases. Now, coming to residual inophthalmos, most likely the inophthalmos is because of incomplete correction of the fracture.
So that they also have to stretch it like.
May I request everyone to please mute themselves if they are not speakers.
Admin, please mute yourself. Support admin. Yeah.
Hello.
Support admin, please mute yourself.
So regarding the residual inophthalmos, FDT will not really help us to tell us whether inophthalmos is because of entrapment, but most likely the patient gets a diplopia if there is any entrapment within the implant and if FDT was not done. So it is more to rule out an entrapment, and if we have not done it and we suspect it, then an MRI or a dynamic MRI will really give us a clue as to what is happening in the post-op period.
Yeah, thanks, Preeti. Actually, I just wanted to raise this point regarding the FDT, I think, which is a basic test, but important after we have done the fracture repair. Thank you, Preeti. Thanks a lot.
Thank you.
Thank you all for
Dr. Robert, sir, any comment?
I would just like to thank all the experts for having brought out all the valuable points in the management of cases of orbital fractures. We'll just add a line to say that now we have better tools, we are able to image better, we are able to understand the exact amount of defect that has been created, the volume change that has been created, and are able to reproduce the anatomy rather well by having 3D reproductions. You can do a good planning beforehand. You can, when required, have patient-specific implants as well, based on that 3D reconstruction and based on volume measurement. So all those have made a big advancement in the management of complex fractures that have been spoken about. So I think it's time to move on to the next one, Purendra.
Yeah, I think Dr. Hardik Khurana has to video.
Yeah,
please.
Dr. Hardik.
Yes, sir.
Yeah, Dr. Hardik, any problem?
Dr. Hardik, Mac or Windows now? Done, sir. Just sharing it. Is my screen visible to everyone?
Yes.
So I shall be starting. Good evening, everyone. I shall be starting on my presentation of an orbital trauma. It includes the introduction. We'll discuss about the shotgun injuries. The shotgun injuries to the eyeball are rare but devastating, often leading to severe visual impairment or blindness. These result from high velocity impact of multiple projectiles, causing extensive tissue damage and require urgent intervention. The past literature, as we have seen, indicates a poor visual prognosis and increased percentage of cases require enucleation due to extensive extent of trauma. And this is the case report showing a 24-year-old male presented with sudden onset diminution of vision in left eye for 2 days associated with pain due to the injury of multiple shotgun pellets fired at distance, which is quite uncommon in India. As well as on examination, the left eye showed PL denies and IOP was low. The conjunctival laceration and grade 4 hyphema was present, as well as posterior segment couldn't be evaluated. The ultrasound B scan showed an intraocular foreign body, as we can see in the lower image, as well as a deformed globe with posteriorly dislocated lens. And as we can see the laser pointer, there is a hyperdense hyperechoic contents showing a foreign body. The X-ray chest showed multiple pellets dislodged at various sites of the body. The CT scan showed a left occipital lobe showing a pellet in the left occipital lobe, as well as at the level of orbit, and a hyperdense gunpowder spread. Initial management, as we did, was oral antibiotics, NSAIDs, vitamin C, proper positioning, and advised topical steroids, topical antibiotics, and systemic stabilization of the general physical condition. Follow-up shows a retained blood clot as well as aqueous flare. We plan for enucleation under local anesthesia and advising for sympathetic ophthalmia. So we discussed basically visual outcomes, and this case highlights the importance of early management and early treatment, as well as accurate imaging and collaborative care, which was necessary. And continued research into early intervention is required. Thank you.
Thank you, Dr. Khurana. And you have highlighted the importance of a case of blast injury and brought into for discussion a case with the PL inaccurate. So I will like to add the comments from Dr. Prem, if he is there. In a PL negative case, a PL inaccurate case, PR inaccurate case of trauma, blast injury.
Yeah, no, I think that these are incredibly challenging cases. And, I think if Annette is still on, there has been a lot of work that has been done recently to show that we should not give up on these eyes, and that even though there may be severe injury, in the past we may have just said, oh, we cannot do anything, we should enucleate, we don't know what the outcome is going to be. Our recent experience has shown that that's not true, and that there really is benefit in trying to assess the vision as best as possible, but then to repair as much as you can and really give that eye a chance. And I think from an optic nerve perspective, it's very hard in those injuries to know if there is irreversible optic nerve trauma. If there is, well, I mean, that's unfortunate, but that's again a judgment that may be made later on and not in the heat of the moment when that patient with an injury presents.
Thank you. Thank you. Anyone else who want to comment on this?
I just wanted to make a small comment. I agree with Dr. Subramanian, and sympathetic ophthalmia, if it has to occur, would occur from the trauma. But the management of sympathetic ophthalmia, the detection of sympathetic ophthalmia is much better these days. And a fear or a worry that sympathetic ophthalmia would kind of affect the contralateral good eye, certainly by no means is a reason to give up on this eye in this date and age. So I totally agree with Dr. Subramanian on that.
Can I
And
ask?
Tarjani and I both had the pleasure to hear Dr. David Jordan speak on an analysis of sympathetic ophthalmia that has been done in a great in a review of the literature, a systematic review. And really some of our ideas about SO risk may really be overstated and may be erroneous. And so that combined with what we just mentioned about our ability to treat it, again, I think changes our perspective.
Sir.
So if I go by the question, one question. We have a pellet in the occiput. We also have it in the orbit. We also have intraocular pellet. precedence. Like first he has to get neurosurgery opinion, and then we should proceed with ocular reconstruction, or how should the approach for if a patient lands up in a comprehensive ophthalmic situation, a small clinic?
I would say that from a neurosurgical perspective, the occipital pellet may actually not need any urgent intervention. There are times where definitely the surgical procedure going after that, similar to when things are deep in the orbit, it may actually be better to let the body heal that and not go digging for things deep in the occipital lobe where it may cause more damage at that point. Knowing the composition, if you can, of the pellet can help you to determine what the toxicity of that might be. If it doesn't contain copper or other reactive substances, then that can be helpful. So I think you're right. It's absolutely a multi-specialty consultation that has to occur to set these priorities. But in fact, it may be that the globe injury is the one that really needs repair, and the others could potentially be a delayed procedure or even no procedure.
Dr.
Yeah, even the orbital foreign body is distant from the nerve. It's not something that any of us would go chasing.
Sir,
I think
just
you're right.
I want to add few points. In case of in case of a foreign body intraocular, definitely there is an embryone. In such cases, ultrasonography is totally contraindicated. No need for any ultrasonography. Even in his patient, that is intracranial foreign body also. So one CT scan is enough. So no need for any ultrasound first. Which is my one observation. Second, as Dr. Prashant asked regarding, is it possible to treat in a single clinic? No. If there is a medical legal point of view, if there is a intracranial foreign body, so better we can shift the patient where there is a ICU facilities. So there may be some vessel which may be rupture at any moment near that one. That's one. Otherwise, no need to remove that foreign body. Sometimes it may be without removal also we can observe, but it should be follow up that patient in a very close follow up with the proper ICU facilities.
And thank you, Dr. Das, and we'll move ahead to the next presenter. Dr. Bharat Mehta, has he come? Is he there?
He's stuck up in an emergency, so I think we will go with the cornea segment now.
Cornea segment. So Dr. Anand Partharthi. Dr. Anand, are you there? And Dr. Chewang Bhutia.
Hi, good evening.
Dr. Anand,
I'm here. Hi, Purinder.
Hi. Dr. Chewang, are you ready with your presentation? You will be the next to present. You please keep yourself ready.
So first we have Dr. Anand.
First is Dr. Anand.
So you can unshare your screen meanwhile.
Anand, please share your screen.
Yeah, okay. Are my slides visible?
Yeah.
Okay. Thank you so much for allowing me to be a part of this. And trauma is something that is always challenging. And I do hope that we can have a good discussion on this. So one of my mentors always used to state that trauma doesn't read the textbooks. And once you do that, you realize that once you go deeper into it, the way trauma presents in different methodologies, you can see they do not have uniform presentations. So you can have involvement of only the cornea, you can have involvement of the cornea and the sclera, you can have stellate, linear, irregular, only limbal, also only central corneal as well. And sometimes you can have association with a cataract as well. Now, this is an 11-year-old boy with a pencil tip injury in school and has a fairly linear central corneal involvement. And if you follow the principles of management of symmetrical suture placement, whereas you have both parts of the anterior and the posterior lips of the trauma well opposed, you would actually get good apposition. The second important point about principles of management is the way the entry of the angle of the needle is. It always needs to be at 90 degrees to the wound because that gives the best results. Now, this patient actually did quite well. We followed these principles, and on the OCT, you can make out very, very good apposition of the wound. This is one other patient, a 10-year-old boy with injury with a stick. Now, the difference is, of course, you can make out the amount of cellular reaction, the irregular cut, and the wound edema which is there in the cornea. Now, once we go ahead with the formation of the anterior chamber, you do the corneal tear repair, you find in the second, third, there's severe reaction both in the anterior chamber and in the cornea. And this now needs to be treated not as a corneal tear alone, but you need to also look at the infectious keratitis component, and you would treat it like infectious keratitis. In this patient, we got Staph aureus with the culture and sensitivity, which we treated. And over a period of time of about 3 weeks, the wound actually well healed. And then we went ahead with the suture removal at the second stage. Very occasionally, you are lucky, like these two patients, which had clean visual good visual improvement with removal of sutures. They, with a contact lens or a glass, they actually see well. The picture on the lower had pure limbal injury. We were able to save the iris and suture, and since the patient had a clear lens, they actually did well. Very occasionally, you do need to go in for early cataract surgery in some of these patients because of an intermittent cataract. And in this patient, we went ahead with gluing, because gluing required a slightly irregular cornea and we needed to form the AC. And if the gluing is well done, most times you can go ahead with the cataract surgery alone and place the lens. So if you have a patient who has coexisting cataract with a corneal tear, you can go ahead reasonably early. You don't really have to wait very, very long. If the patient presents late and you want to actually manage the astigmatic part, it is possible to do it multiple ways of doing it. In this patient, we manage the astigmatism with an astigmatic keratotomy in addition to placement of the lens. And this is, of course, topography guided. So you do a topography or a cirrus, whatever you have, and usually about 4 to 5 millimeters in the corneal relaxing incision. Most of them actually do quite well. And then you go ahead with a standard cataract surgery. In summary, when you have corneal tear, it's important to follow the principles of corneal tear closure. The coexisting infection needs to be treated. In about 30 to 40% in our experience tend to have coexisting infection. The culture sensitivity is important, but in a lot of these patients, a combination of gram-positive and gram-negative coverage is important. Early cataract surgery can be attempted if the wound is good, and if required, you can use synovial glue. The astigmatic management has multiple approaches. You can take an incisional approach or a laser-based approach, whatever has access to you. Thank you so much.
Thank you, Dr. Anand. It was a very nice presentation, a comprehensive way to explain right from the variety of trauma cases, their management with or without cataract, with or without the involvement of the uveal tissue, and how would you manage a case with when there is a large corneal scleral wound? When the scleral extension
I think this is extremely important. When you have a corneal scleral wound, Dr. Bhasin, you would probably then look at involvement of the retinal surgeon, depending on the extent of the involvement. Usually up to 4 to 5 millimeters, we always do a CT scan. If it's covered by conjunctiva, we definitely do a CT scan, do an exploratory surgery just to see the extent. And usually we would keep the retinal surgeon in the loop. In really large extensive traumas, endophthalmitis is almost something that we need to keep in back of our mind. But the principles of surgery, which I mentioned in terms of suture, in terms of making sure that you get a good seal, in terms of management of any coexisting problems like a cataract, uveal tissue involvement, and late onset glaucoma needs to be done. Of course, I think at each stage, you need to make sure that the complications are kept in mind, because trauma is something that probably for the next 6 months patient is going to come to you. So you need to be aware of multiple complications that can occur.
Dr. Sushmita?
Yes, sir.
Please.
Yeah, I would like to add a few points. Yeah, very excellent myriad of cases, Anand, very nicely managed. I'd just like to add a couple of points. First was that case about where you saw, hypopyon in the eye in the post-operative. Yes, this happens on the first day post-op. When you see the patient, the anterior chamber, you may not see infiltration and hypopyon, etc., but they appear on the second day or the third day. So one has to be very vigilant. And the point is that we need to keep these patients under close watch, because oftentimes it could be in infection. So this needs to be treated. If we see whitish matter, sometimes it could also be, ruptured anterior capsule and some amount of flocculent lens matter that is there, that could be taken care of while we are doing the primary repair. And regarding the point of traumatic cataract, yes, if there is a lot of flocculent lens matter, or a lot of it is not majorly the anterior capsule is breached, we usually go for a lens aspiration, but we usually defer the IOL implantation, because typically till the sutures are there. So typically we usually wait for about 2 months for the suture removal, and once after about say 4 to 6 weeks, we do a topography, figure out how much is the astigmatism, and then go ahead with the secondary IOL implantation. So this is something that we always explain to the patient the day they present, that multiple procedures or multiple interventions might be required. We may not be able to do that. Whatever we are doing on the first day may not suffice. Whatever we are doing is to just close the globe, and is a globe saving. A subsequent visual rehabilitation will take future procedures. And regarding the point on astigmatism correction, again, AK is a good option, though AK, as we know, traditionally AK is not, it kind of reverses back in 6 months to a year. So if possible, I think I would suggest topo-guided PRK. But yeah, if it is the incision is bang in the center of the pupillary area or something like that, then again, PRK may not work out. But yes, and PRK also, the maximum amount of correction that we can do is only up to about 6 diopter of astigmatism. Beyond that, patient has to be told the option of wearing contact lenses or glasses.
Good points, Sushmita. I think probably the only thing I would add is, usually most of these patients who have a chance of inflammation, I prefer to give fortified drops in the primary presentation rather than a broad spectrum. So I find that most of them tend to respond much better, and chance of any staph or strep infection is taken care of.
Yes,
I have a point to make. Purinder, can I speak?
Yes, please go ahead.
Of course, a good presentation, Dr. Anand. Only thing is that I feel that we should not hurry up in removing the cataract. We need to settle down the inflammation first, get a CT or a MRI done to see if there is any kind of intraocular foreign body, and then go ahead with the stages of management. We basically need to put the patient, we have to bathe the patient into steroids in order to decrease the inflammation. Second point is what Purinder asked you was regarding the corneal scleral wound. Yes, we can have the retina surgeon, but if you have got a scleral wound involvement, there would be a lot of bleeding, there would be a ciliary body exposure, there would bleeding probably in the anterior chamber, probably in the posterior chamber as well. So it'll be difficult and the eye would be soft. So it'll be very difficult for the retina surgeon to intervene. And the most important is what we have learned for the last 30 years is, even beyond that, is that the limbal anatomy needs to be maintained. The limbal, if there is a corneal scleral wound, you need to maintain the limbal anatomy. Of course, regarding the suture, you have already mentioned that it should be perpendicular, everything is fine. But these are the basic things which I feel that I would wait for cataract surgery till the eye is settled down. I'm not delaying it by 4 months, 6 months, but let the inflammation settle down. In case the patient develops, you said there's a staph aureus or something, after you accordingly treat it. But I think that cataract surgery needs to be waited. Put the patient in steroids if it's not diabetic, and do the investigation. And then accordingly, you can plan with the VR surgery and so. But in a scleral wound, I think anatomy of the limbus, anatomy of the eye needs to be maintained. It'll be very difficult for a VR surgeon to go. I think I would put this question to Prashant, who himself is a VR surgeon. Prashant, any comments on this corneal scleral wound at the time of injury, intervening yourself?
Yeah, me as a predominantly a VR surgeon and to some extent doing phacos and repairs like this, what I would prefer is a primary repair, and as far as possible, not touching the capsule and preserving the capsular bag as much as possible. The advantage of doing a secondary procedure is that one thing is inflammation is under control. All the parameters are under control. Second thing is, even if there is a trauma to the capsule, that capsular trauma itself undergoes a fibrosis, giving you an adequate support in spite of having a deficiency, be it in anti or a posterior capsule, giving you an adequate, fulcrum for support of a sulcus or sometimes majority of the cases PC. While if you go in an acute phase, those tears goes on increasing when you're trying to manipulate the cataract surgery during primary repair. So this is what I preferably try to do. And third thing is, I personally always prefer to err on the better side. Whenever I see that the trauma is likely to have an organic cause, I might also not hesitate in in giving an intravitreal antibiotic along with a routine thing.
I agree. I
I
mean,
think there are a couple of
one
points
thing is
you
there.
raised, Dr. Sanjeev and Prashant. The reason I mentioned was just to show that sometimes you do not get a perfect seal. Second, in that patient, we had a raise of the intraocular pressure, which I mentioned during presentation. So that was the reason to go ahead. You can, of course, if the pressures go up, you would struggle with managing the pressure medically, because then there is such a lot of drops. You need to manage the trauma, you need to manage the glaucoma. So sometimes it does become tricky. I agree with the point that you may not put a primary lens, maybe go back later and put a secondary lens. But the indication for surgery in that patient was the pressure.
Yeah, that exceptions will always
You
be
can
there, Dr.
remove
Anand.
the cataract, but don't put IUL. You can remove the cortex, loose cortex. You can remove the cataract. That's what we do at that sitting. But we don't put an IUL in that sitting because of one more reason, that our IUL power calculation is not accurate because of the open globe at that time. So we have to put an IUL power which you have to anticipate from the other eye. So that is what is very, very important. Unless until the tear is small and not in the visual axis, it is in the paracentral area, then and a small tear, 2 millimeter, 3 millimeter, clean wound, no infection, then we can remove the cataract surgery after doing the suturing. Otherwise, rest of the cases we do in a secondary sitting only. In all the cases, that gives a very good the results, as Dr. Prashant and Dr. Sanjeev has added. Thank you.
I think Dr.
Thank you for that wonderful discussion. Before we
I think
move
for
on,
amount of
I
time.
have the pleasant task of thanking Annette. It is quite late for her. It is early next morning in Australia. So I would like to thank her because she would like to leave now, but would say that the points she made were wonderful. We have had BET for a long time, and the availability of iGates data has given us the opportunity to improve upon certain things which she so beautifully pointed out. She pointed out the importance of highlighting the changes that take place in central cornea. So there is a paper that that group has prepared on that. Then there is another aspect of dividing the zone 3 injuries between those beyond 5 to 8 and up to 5, so that there is 8 to 12, 5 to 8, 8 to 12, so that you get a better prognostication. And there is an improvement on OTS also, as she pointed out. So I think there are wonderful changes on the anvil, and the group is doing great job with the data available from iGates. And I would request everyone to join in with iGates and put in the data so that these newer advances can all come. And we have Annette to thank for all that, and thanks for presenting them. If there are any questions for her, you can put it to her before she leaves.
Thank you, Annette.
Thank you, everybody. Thanks, Ashok. Sorry for not staying longer.
No, it's early morning for you. Good night.
Yeah.
Good night.
Dr. Prashant, one thing can I ask? Dr. Prem is about has to leave in another 10 minutes. Can we take discussion on optic nerve cases first? Prashant?
Sure. Yeah. Why not?
Dr. Sunil, are you there? Can you present now? Sunil Morikar?
And may I also request General Parihar to also participate in the moderation?
Discussion.
Yes, I'm here, yeah.
Parihar is here.
Welcome, sir. Sunil, please.
Can you hear me?
Yeah.
I'll just try to get to my.
Upload your presentation.
And Dr. Purendra, we are running quite late. We should be ending our discussion a bit.
Cutting down on our discussions.
True. And
are you getting me?
Dr. Devdutt is also there now. So you be ready for the next presentation after this.
Yes, sir. Yes, sir. Sure. I'm ready.
Are you getting my presentation?
Yes, boss.
Is it there?
Yes, we can see it now.
I don't know how to go into the presentation mode. Yeah, is it there?
Can we have it in a presentation mode? Yeah, fine, great.
Okay, so I'm just going to run through to three cases which we have applied some new principles. There's no financial interest, and I have to thank all the money comes from MGM Medical College because they've been sponsoring half of my work. So I have to acknowledge my department there. Traditionally, the indications for optic nerve, optic canal decompression was indicated after giving steroids for some days. I'm not going to go into the details of that. But then came the crash study, which talked about the issues with systemic corticosteroids. And it questioned through many randomized control trials. And there were a lot of studies. I'm not going to go into the gist of it all. But then Cochrane came up with something where it questioned the role of steroids in traumatic optic neuropathy, usually in the direct cases. Then also the other thing that was questioned was whether you should do surgery or not give any treatment at all. So do these cases really benefit with doing anything, or do we just leave them alone and whatever improvement is going to occur because it was going to occur in any case? But then what Cochrane talks about that there is no evidence. But then the take-home point with I've been working with Cochrane for the last 14 years, done all their modules and all. It simply much comes to absence of evidence is not evidence of action. Absence of evidence is not evidence of absence. So traumatic neuropathy, optic neuropathy, there is no great evidence of surgery being useful. That really does not mean that there is evidence that surgery doesn't work. Because there are a lot of people who do question that. This is the surgery that we do. You can see the optic nerve here. Is my cursor there? Can you see that? Yeah. So that's the optic nerve, and this is the fragment there. And generally, you just end up pushing away the fragment from where it is impinging upon the optic nerve. That's the simplest thing that we do. I mean, most of my cases are absolutely like this at the end of the day. But what are the other things that we have tried using? We stopped looking at just color vision and other affections. We started looking at inside color abnormalities, and we realized that the color abnormality also gets corrected. The imaging improved. The direction-coded color maps, prognostic imaging in terms of VP, the interest, we've been looking at fundus photography. These are the assessments that we're doing, OCT and damage assessment, because there are times when you have a traumatic reserve loss glaucoma, because you've got RNFL nerve fibers which have been lost. Then some of them are being lost over the years because of an angle recession. So you got somebody pulled my hair and made me bald, or somebody injured me and I'm getting bald over the years. And somebody's just holding on to my hair. So those are the three analogies that I talk about. So we looked at pre-op, post-op. We also looked at ultrasound images to look at what is the prognostication. Because and then we started using these closed protocols. And when we look at these closed protocols, we look at optic nerve supply. So we looked at Doppler and how much is the supply and how much of it is compromised. And the three factors that we associated with poor prognosis was a reduction of peak systolic volume, and end diastolic velocity was also reduced, and an average mean velocity is reduced. So these are the factors associated with poor prognosis. So we don't say it works, it doesn't work. In this particular case, is it going to work? So we also looked at what we call as an electronic stethoscope orbital auscultation, and a lot of people started laughing at me saying that that's not where you put the stethoscope, you're supposed to put it on the chest and all. But then these are the ocular phonograms that we have in patients pre-operative. You can see that there's absolutely no flow. You don't need to do a Doppler. You can actually do an electronic stethoscope and you see there's no flow. And post-surgery, there is a massive flow. And this is what you want to show to patients when you're waiting in that time period for them to recover. The flow has improved, but the vision has not improved. So I've been sitting on my leg. So I tell patients I've been sitting on my leg. I've gotten up and I have started my circulation. It's not going to start working right away, but you see the Doppler and the phonograms are showing that there is reperfusion. There's a surgical review of many of the cases, and these are 685 cases recently. So post the Cochrane review, which said that probably there's no evidence that surgical treatment works. There are 2 more studies of large numbers which have come in. There's a traumatic update which talks about this thing. But what we applied here is what we call as artificial intelligence, brain and optic nerve. So there might be times when your brain is affected or your occipital lobe is affected because of a polytrauma, and you think it is the optic nerve which is a problem. And so you do an AI and try to figure out both the things, because it's practically impossible for a person to judge something subjectively. So you go objective. Your algorithm gets further refined when we started using the Wolfram algorithm, Wolfram language for what we use for papilledema. We started using it for optic nerve also. And then we realized that then whether it is the brain which is injured and that is what has gone wrong, or whether it is the optic nerve. And then when we looked at combined cases, this is a particular case in which we realized that we have to do something for the optic nerve. So the AI tells me whether we should do something or whether we should not do something, where is the problem and what is the prognosis. And you can see that these are the multiple implants that are put in. There is an implant that has been put up there. There is an implant which is put up on the roof, on the floor. And there was a chip there, and we've taken out the chip as well. There's another patient. I'm sorry, I should have edited that picture. But there's a hypoglobus, and in that hypoglobus, the patient had a visual compromise. And what we realized that it is the visual compromise is because of a stretch of the optic nerve. So you take my hand and you stretch my hand, and my hand is numb. You just release my stretch, and the numbness is gone. You don't need an optic nerve schizotomy or a removal of a fragment or something like that. And we then reconstructed our hypoglobus by using a cartilage graft and holding the cartilage graft with titanium plates there. And that's what you can see. The patient is, the hypoglobus has been put back. And this is what the AI told me. The AI told me, don't do anything with the optic nerve. Just put this globe back and the vision will improve. And there it improves. There are multiple algorithms that you will probably need to do when you're putting multiple screws. There is, like the first case I said, you're going to put a screw here, you're going to put a screw here, you're putting a screw there. So then you end up using a lot of algorithms in this thing. So we have been doing research with biostatics with Wolfram language and trying to figure out not just what to be done, and also what is the prognosis and what is the pathology. And we've got the national award for the thing in papilledema, but we are working on that with AI. And anybody is interested in working along with me, this is my email address, that's my phone numbers. I mean, just reach out to me, and we'll probably look at AI with traumatic optic neuropathies. The end of the day, I would like to stress on the point that we cannot and should not be looking at Cochrane reviews and things like that in a particular disease like optic nerve injury, which cannot be put into one basket. All of these cases are completely different. Each of these cases is different. So we cannot say that optic nerve schizotomy or a traumatic optic nerve neuropathy decompression works or does not work. It will work in a particular case. It will not work in a particular case. I think the approach so far has been wrong. So what Cochrane is now doing, we are looking at what is called as network meta-analysis. So we look at Bayesian network meta-analysis.
Can you please sum up, Dr. Sunil?
Yeah, that's what we are trying to do. So network by analysis, and then you realize that each of your cases is different, and you have to use AI there. Thank you. Thank you very much.
Thank you. Dr. Prem, please your quick comments on this. Dr. Prem Subramanian, please.
Sure, no, that's a fantastic presentation, and I think you hit on many of the high points of the challenges we face in taking care of patients with traumatic optic neuropathy. I agree with you that we cannot rely on retrospective analyses like Cochrane Review at this point in time because there have been significant advances. And I think in particular, the safety of endoscopic optic canal decompression allows us to operate on more patients and to collect data in a prospective fashion and to really look at, just as you said, who is likely to improve and who is not. And that's where I think that the combination of randomized study along with AI application is going to help us to really get better predictive algorithms so that we can accurately say to our patients, we think this is going to work, or we're going to do this. We don't think it's very likely to work, but we think risk is low. And so let's go ahead and do it because there is a small chance that you might recover. And I think that's really important, both from a patient care standpoint and a scientific standpoint, because it then allows our colleagues to have more confidence in what we are doing and not to look back at things like prior meta-analyses and say, oh, no, you should never intervene for these types of cases. So I'm really thankful that people like you are doing this kind of research in settings where you have access to a lot of patients with trauma. For better or worse, fortunately, in the West, we have a lot less traumatic optic neuropathy because of safety standards. And so I don't have the ability to accumulate the number of cases like you do, but I am currently collaborating with some people in Singapore and hopefully in Vietnam, where they have a tremendous amount of TON, to try to do these similar analyses. And the more data we can collect, the better.
Wonderful comments, and thank you, Dr. Sunil. May we move further to Dr. Devdutt Thomas for his presentation?
Yes, sir.
Please upload your presentation.
Yes.
We'll request all the presenters to present their case or a video within 2 to 3 minutes, so we have adequate time for more discussion.
Good evening, everyone. Thank you for the opportunity. I would like to just talk about very specifically about the optic nerve neuropathy, traumatic optic neuropathy. And I have the opportunity to work in a very big trauma center in Coimbatore, that is Ganga Hospital. So where we see a multiple type of injuries. And I would also am called to give my opinion on different modes of road traffic accidents and the ophthalmic trauma and ocular trauma patients. So as I go and see the patients, I see very many type of patients where the entire patient, there be very challenging situations like very tense periorbital ecchymosis may be there, which is compressing on the globe and in the optic nerve. And we take a relevant history and timing of the injury, which is very important, and whether the patient has come within the 6 or 8 hours after the injury. And most of the times they come a little later. And we look into the entire set of pattern of diagnosis, and right from the anterior segment, the pupillary function, and intraocular pressure, fundus evaluation also is done with an indirect ophthalmoscope. And the color vision is recorded to look for a red desaturation and a confrontation field of vision. These are the basic things which I do. And as we all know, whenever there's an outer orbital third injury, which is present at the level of the outer angle of the orbit, that creates an indirect optic nerve injury into the optic canal region and into the strut of the optic canal, as well as the greater and lesser wing of sphenoids. So we are all aware of the situation that more males are affected, about 85%, and patients with midfacial trauma and fracture and patients with lateral orbital wall fracture are more commonly associated with optic nerve, traumatic optic neuropathy. And this is a case one where a patient is presented to us with severe vision loss of 2/60 in his left eye with a positive RAPD, and he had a red color desaturation, and ordered for a 1 millimeter section of CT scan to rule out the optic canal injury specifically. And whenever there is a suspicion of the injury to the lesser wing of sphenoid, which encases the optic canal, we most commonly come across this the traumatic optic neuropathy picture. And we make sure that there is no impingement of the optic nerve sheath with any bony fragments. So this is based on the patient's presentation. And we subsequently, when the patient comes for follow-up after 1 to 2 after 1 month, I always do a field test to make sure that whether how much of the visual field is preserved for the patient, whether there's a loss of peripheral field with the central tunnel of vision. And we look, and I also do the VEP response for the patient. It is also done at the time of the injury for the sake of documentation and for because they are all mostly medico-legal patients and who come for the assessment and management. And they also have multiple polytrauma patients also. So we do not have the thing to shift the patient to a eye hospital to see all these detailed examination. But whatever is possible on the bedside, we do. And then when the patient comes back later on, and we explain about the prognostic factors based on the severity of the injury and the initial presentation of visual acuity for the patient. When the patient has a better visual acuity at the time of presentation, his chances of recovery are much better with the systemic steroids. Whereas when a patient comes with a very severe loss of vision like this, and the patient in a state of unconscious state or a mentally deranged state, they are in a very poor prognostic factor situation. And I always make sure to do a proper swinging flashlight test to detect the RAPD. And we also have to differentiate it from traumatic mydriasis, anisocoria, traumatic mydriasis, and neurological third nerve lesion. These are all the things which you need to rule out and to make sure the patient has a traumatic optic neuropathy in patients. And the role of neuroimaging is mostly it's a CT scan, a 3D scan, reconstruction image is done, and the MRI is done for patients when we suspect a optic nerve compression due to a hematoma or a soft tissue lesion in the orbit. And mostly the 3 mm slice cuts are ordered, and then when we suspect an optic nerve injury with the clinical presentation, we do a 1 mm slice cuts for suspected optic canal injuries. And always we make sure to rule out optic nerve avulsion by doing a dilated fundus examination and indirect binocular indirect ophthalmoscopy. This is a case 2 patient who presented to us with a moderate loss of vision of the patient lady had the best corrected visual acuity of 6/24 in the left eye. And she had on a confrontation, grossly, she had a inferior altitudinal field loss. And on a computerized perimetry, we were able to pick up the objective loss of visual field. And we have the associated other orbital injuries with the traumatic optic neuropathy, where a patient with a severe blowout fracture can also have fractures involving the lesser wing, greater wing, medial wall, lateral wall, and all this can produce an associated swelling inside the orbit and compress on the optic nerve. And the patient with the roof fracture, patient with tense periorbital ecchymosis, and patient mostly with the lateral wall fracture have the very commonly associated with traumatic optic neuropathy. And some of the poor prognostic factors indicated are basically the patients with the impaired mental state, bilateral optic nerve involvement. There's no improvement in vision after 48 hours, an absence of visual evoked response on VEP testing, and optic canal fractures on neuroimaging, and patient presenting with no PL, and severe grade RAPD, grade 4 RAPD. And these are all the patients who are, we explained to them about the very poor prognostic indication. And and we are all aware of the IONTS study, where the observational group only had the better outcome after a period of time. And though in this situation, when the patient comes, they always expect us to give a good amount of medical treatment, whatever is possible, and then we give the patients.
Can you please sum up, Dr. Thomas?
Yes, sir. So the thing is, when the patient comes with a severe the optic nerve injury, when we do the observation rather than giving a treatment, when the patient has a moderate visual acuity at the time of presentation, they have a better indicator, better prognosis, and then we give them mega dose of steroids as in the optic nerve treatment trial. But the mega dose followed by a bolus dose followed by a maintenance dose. So, and now the new concept of the erythropoietin injections, 10,000 international units is also being tried for patients and which increase the color vision, but may not increase significantly the visual acuity compared to the steroids. And surgical decompression of the optic canal is done only when there is an impinging bony fragment. We consider doing a thing, but there are limitations of CSF leak, meningitis, and other associated head injury. So, in summary, the patients who come with different stages of the optic nerve injury are managed with a high dose of steroids, and then the management of surgical management is done only if there is an impingement of optic canal. Thank you so much.
Can we request Dr. Prem to comment on this?
Yeah, very comprehensive overview. The one thing I will add is that the point that was made about the point of injury to the skull or to the brow being a prognostic indicator of the likelihood of traumatic optic neuropathy is very important, and there are plenty of studies showing how that really is a big risk factor. And in fact, we are in the process of developing an animal model reproducibly to direct force to the brow to allow us to better study TON in the animal model and be able to develop therapeutics around that. So a very critical point in terms of patient examination and likelihood of finding TON.
Thank you. In the meantime, when this Dr. Sonam, you will be uploading your presentation. A quick reply from Dr. Prem and Dr. Sunil, whether we should give steroids in all cases, bolus dose of steroids in all cases of traumatic optic neuropathy, and when till what time we should give.
Dr. Purendra, before Sonam, we will have Dr. Chevang. She also has an optic now case, I believe. So, because Dr. Prem has to. Dr. Chevang, can you be ready with it? You can share the screen. Meanwhile, Dr. Prem, all those comments on Dr. Purendra's.
Please, sir.
Quickly, as far as steroid, I think it remains somewhat unclear that steroid is a benefit. Many times they are given because the patient is low risk. I don't give it when there is head injury as well because of concern for making the outcome of the head injury worse.
So when there is no head injury, then in such cases only
it can be given. I am equivocal on doing so because I do think the data around efficacy of steroid in TON is still somewhat poor. And I think that, again, the further study hopefully will help us. But I think surgery is going to be the more powerful treatment for these patients rather than the doing steroids.
Right, Dr. Prem. I think I agree with that the results with the steroids are quite equivocal, and there is no evidence at this stage to use them. But if you were using them, what time frame would you suggest?
Yeah.
Say within a week of the trauma, or would you still give it if it is later than that? You know, it often gives the patient a feeling that something is being done. That's the most important reason why people are using steroids.
Yes.
Of course. I think that is truly the reason why they are given. We tend to say 48 to 72 hours because theoretically any axonal swelling by that point should start to spontaneously improve. But I have seen them given later. And you're absolutely right, Dr. Grover, that it is treating the patient as a whole by giving them the feeling that something is being done rather than a strong sense that it will be medically effective.
And the mega doses that were once talked about, like the spinal injuries, are absolutely out because we all agree that probably they contribute to greater mortality.
Should we give after a week? After till what time should we give? 3 days, 2 days, 48 hours, 7 days? Because I have seen people giving after a month also.
I have seen others say up to 1 week. And I think, again, this is where there really aren't data, and it is more of almost a social situation of being in the conversation with the patient and seeing what it is they want to do. I think Dr. Sunil has a point.
Sunil, please.
If you were to really ask me, I would look at the patient in the entirety and look at his head injury, look at his occipital lobe, look at his swellings there, consult the neurologist and the neurosurgeon as well. And like Prem said, look at what element of head injury is there, and if it is something that's going to cause you an issue, I would not give, like Dr. Devdutt said, I would not give steroids at all because that would be counterproductive in some cases. So whether it's going to be counterproductive, whether the risk is more than the benefit, that is what needs to be assessed. That is what I think Prem has also been stressing, right? And for me, I end up right now, if you ask me, I end up putting all of them on some AI model or the other to decide on the background. For me, there are too many variables that are there in a patient with this thing, and it's humanly impossible for any person, no matter how experienced he is, to factor in each variable and try to figure out how much is the thing that affects that particular patient. So if I don't have an AI, I will ask 5 surgeons around me. So there will be 5 people who, so you indulge in what is called as metacognition. So I might have thought differently. It's an elephant. 4 of us might think it is a pillar. The 5th one will tell me it's a fan. The 6th one will say it's a fan, and then we'll say it's an elephant. Let's not give the steroid. So it's important for you to see the elephant in the room. I mean, it's usually there, but you will just see the pillar. So that elephant in the room doesn't need the steroid. You don't give it.
Thank you, Dr. Sunil, for your comments, and Dr. Prem as well, and Dr. Grover. Thank you. May I request Dr. Shivang to share her presentation?
So is my presentation visible?
Yeah.
Yes, yes.
Good evening, everyone. So my topic for the presentation is traumatic disinsertion of the inferior rectus. So I'm presenting a case of 24-year-old woman who presented with trauma wherein she was hit by an edge of a car door below her right eye. And then she came with a complaint of pain, redness, swelling, and restricted movement, specifically in the down gaze. However, she had no visual complaint. We have to keep in mind that the trauma is a blunt type of trauma and there was no any significant external injury. So on examination, we can see that that her visual acuity at bedside was normal. The intraocular pressure was normal. Ocular movements, however, was restricted in the infraduction. When Hirschberg light reflex was performed, it was displaced downwards at the limbus. The force duction test was not restricted. Cover-uncover test was unpredictable. Alternate cover test was insignificant. The eyelids had lid edema and ecchymosis. Mild mechanical ptosis was there. And in conjunctiva, there was a laceration which was 2 millimeters just inferior to the cornea. Sclera was insignificant. And when we had a thorough, careful, closer examination of the extraocular muscle, what we observed was there was an inferior rectus laceration which was 2 to 3 millimeters from its insertion with the muscle stump visible in the inferior fornix, as you can see in the image. Cornea, anterior chamber pupil, however, were normal. Iris, lens, and fundus were also normal. So, for this case, the aim for the management would begin with the preparation for surgery, stabilization of the patient, and tetanus immunization was given, which is must. Lab investigations were performed. Medical management was done with strong IV antibiotics and anti-inflammatory medications were done. And finally, surgery was prepared for under local anesthesia. So the lab investigations were normal. Then exterior orbit, posterior anterior view did not show any abnormality. So for the further assessment, we performed MRI. As you can see out here, in the right eye, there is a slight disturbance and a hyperintensity. This is a similar picture. As you can see in the same picture of the same patient in the right eye as we compare to the left eye. However, in this case, the repair was delayed because there was a medico-legal issue. So when the patient came to us on day 2, there was a problem. So the problem was the patient who had a 6x6 vision now came with a complaint of diminution of vision in the same eye. So on examination, what we observed was the lid edema and the ecchymosis did increase, and the visual acuity in the right eye deteriorated from 6.6 to finger counting at 3 meters, and there was no further improvement. And the ocular movements were same, that was restriction in the infraduction. As you can see here in the video, the pupil had started dilating in the right eye, which was 4 millimeters in size, and the RAPD was present. Then we went ahead with a visual evoked response in this case, and the visual evoked response confirmed that there was a damage to the optic nerve in the right eye. So according to the ONTT trial, we went ahead with IV methylprednisolone 1 gram once a day for 3 days, which was then followed by oral prednisolone, that is 60 milligram per day for 11 days. Then on day 3, surprisingly, after the treatment, vision started improving. Then immediately patient was taken up for the surgical repair. So this is a surgical video where we can see there is the inferior rectus muscle stump, and then the posterior portion of the inferior rectus was surgical exploration. However, we have to keep in the mind that identifying the inferior rectus muscle, the posterior portion is difficult, as after the muscle disinsertion, the muscle does retract back into the orbit. So once the muscle was identified, we secured the muscle and then sutured back at its insertion site. So this is the MRI picture of the same patient after the treatment. Now on day 4, the patient vision improved to almost 624 and patient was almost ortho, which was a restriction in the infraduction as in the initial presentation. As you can see in the video that the patient maintained full duction in all gazes, especially in the downwards gaze, wherein she had a restriction. Now, in the follow-up period, after 1 week, her vision improved to 6.6. Ocular movements were full. It was painless. Then there was a well-formed fornix, as you can see in the picture. Finally, in all the primary gazes, patient had no any restriction of ocular movements. So, by 2 weeks of post-follow-up, patient maintained her vision to almost 6.6 and there was no any restriction of the movement. So patient was happy. Thank you.
You can unshare the screen.
Yes.
Yeah. Dr. Major Parihar, if you want to say something on this case, if you are there.
Dr. Prem, before he leaves, he has to go, I believe.
So, Dr. Prem, yeah.
Yeah, no, I think this again is a nice case that shows that timing of intervention may be really important. And here, because there was a apparent delayed onset of the optic neuropathy, it may be that there was a different mechanism that allowed for good recovery with the medical treatment that was given. And again, speaking to the complexity of these cases, so a very nice outcome for this patient.
Dr. Sonam, Dr. Preeti, any comments?
Yeah, just one comment is that sometimes we get these kind of problems with implant being not in position. Many a times I get references from facial-max surgeons, and I have found that the floor implant has actually cut through the inferior rectus, and then we have resutured it, and the muscle does work in many cases, but sometimes residual hypotropia can be then corrected later by muscle surgery. But identifying the muscle is the most important thing. And usually it retracts towards the orbital walls. And therefore, we really need to go quite deep. It's usually not found near the globe. It is near the walls. And maybe the help of an orbital surgeon sometimes may be useful. Thank you.
Yes, in these kind of cases, actually, a dynamic MRI would actually prove very useful and also to understand the strength or the movement of the muscle. So that is one more thing. And when we are dissecting the muscle, if you can see the vascularity within the muscle, then you can also gauge the viability. If fibrosis is already set in, like Dr. Prem said, timing of the surgery is very important here. That's all. Thank you.
Thank you. I think we can move to the next.
Dr. Sonam, your presentation.
I think before we move to the next one, let's say thanks to Dr. Prem Subramaniam for being with us.
Thank you, sir.
He's always kind and always exceeds to our request. We'll thank him very much. I think it's odd timing for him, but he still did come over. Thank you very much, Dr.
Thank you, Dr. Prem, for being with us and for your expert comments for enriching our webinar. Thank you.
Thank you so much. Okay. So can I go ahead with the presentation? Hi, everybody. Good evening. I think it's a fabulous webinar so far. And at the outset, I'd like to thank Dr. Mehul and Dr. Prashant for giving me this opportunity. And I'll quickly go on to the case. So here is a case of a 4-year-old girl who had an injury with a sharp object. and she immediately presented to our OPD. We could not assess her in the clinic because she was very cranky, but there you can see that there is an upper lid laceration. We took her directly up into the OR, and what we found was something very interesting, that she actually had a common canalicular laceration, unlike an upper canalicular laceration that you would not normally see. So here you can see that the probe is passing right through the canaliculus, and you can see the laceration right there. So how did we go ahead and manage? Since it's a common canalicular laceration, you would ideally want to cannulate both upper as well as lower in canaliculus into the NLD. And this is a short video that shows how we managed this case. Under general anesthesia, parts were painted and draped, and we identified both the ends. We realized that it was coming up through the common canaliculus under the Rittling bicanalicular intubation tube. We have cannulated this. The good thing for us that we had was there's already a laceration there. So after cannulating into the canal, upper and lower canaliculus, we removed it from the area of the laceration and then put it along the NLD. So there you can see down there, you can see that the intubation tube is there right where it's supposed to be into the inferior meatus. So we did like a small probing there. And then we closed the lid, as you can see, with just glue. And this is the post-op day picture of the child at 7 days. So, well, we come across many case scenarios. When it comes to lid lacerations, it can be just a simple superficial laceration, deep involving the lid margin, avulsed lid, or complex, which involve the canaliculus also. Modes of injury can be because of any sharp objects, hooks, or direct trauma. It is very important to assess the globe first in these kind of cases. Remember ABC always. That's systemic evaluation, then followed by the globe, rule out any foreign body, and then finally go on to the lid tear repair. Also, I'd like to just emphasize on the classification by Devi Prasad Mohapatra et al. They divided it into 4 zones depending upon the area of injury or the area which was affected, and divided into superficial and partial thickness, with or without tissue loss, and involving the canthus. So just to confirm, in the interest of time, I'll just quickly skip all of this. And just going back to my topic was the canalicular lacerations. Well, there's always been a norm that if the superficial the superior canaliculus might not be draining as much as the inferior canaliculus, and also the distance of the canalicular tear from whether it's proximal or whether it is distal, whether you need to address both the factors. And this study by Manpreet Singh et al. Actually say that if you have a proximal canalicular laceration, then there's a high chance of canalicular stenosis in the long term. Also, superior versus inferior has always been a debate, and yes, it is proven that you have to cannulate both superior and inferior canalicular tear. You have to repair both of them. The tube that we leave in situ is for 3 to 4 weeks, and then we remove it. So that's it. That's the case presentation. I'm just keeping it quite crisp, and I'll stop sharing the screen now.
I think that was beautifully managed, Sonam. And few points that I would like to say here for the general audience is that canalicular laceration is not a middle of the night surgery. If you don't have the correct stent, or if you don't have the correct expertise or availability of a microscope, you can wait. And studies have shown that even up to 5 days, you can wait and still get good results. And therefore, we should not try to repair it in a hurry. And then once it is repaired wrongly, it is very difficult to redo the surgery later on. Now, second point is that in this case, maybe I would have used 2 mini monocas. That's what I have done for most of the common canalicular tears, so that the iatrogenic trauma to the NLD can be avoided. So 2 mini monocas, and also advantage is that even if 1 mini monoca prematurely falls off or something, at least you have 1 canaliculus which is intubated. And many a times these trauma patients have very inflamed punctum. And if that is there, then these bicanalicular stents tend to cut through the punctum. So that's why having 2 separate tubes usually helps in these patients. Thank you.
That Preeti rightly mentioned. Just I want to add a few points. We should do the surgery always with a good microscope. That's very important. Here you are mentioning the time. Of course, is always under the 100% is good microscope. And as in Sonam showing there is a bicanalicular integration in a single lead. Generally, I would prefer to do a by one lead with a single tube, which is self-retaining single tube. The commercial name is Minimonoca or maybe Orostan, whatever. That's too important. And that anesthesia part is almost we can take can. So no need for go for just if there is a no NLD, no injury to the sac. So there's a no need for any go for beyond sac. So up to the sac we can treat, and now it is with a good quality tube. Even it's easily available all over India, so we can intubate and you can do the surgery and.
Thank you.
Thank you.
And we'll have a next very important talk, which is on Saransh. And as you can see, Dr. Rajiv Raman is there to tell us about the variety of trauma cases, which are very hot and sizzling. List of journal articles on trauma, and he will be telling us about all these cases. So please go ahead with the Saransh, the nice name which you have given.
Saransh, basically, I will introduce it like this. This is a gist of the articles on that particular subject, which has been published in last 2 to 3 years, which has made our understanding of that subject or the treatment modalities a bit changed. So it will be not in very details, just in few lines, what exactly a general ophthalmologist can carry message and how he can modify his way of looking at the disease or treating it. So, Dr.
Thanks,
Raju, I'm
Prashant.
sorry.
Yeah, thanks, Prashant, and thanks, Trauma Society, for giving me this opportunity. And a very nice cartoon of cook. So I thought that I should say that what's cooking today. And unlike what Prashant said that last 2-3 years, I thought that let me, because a lot of things are happening in trauma. So I thought what is happening in last 3-4 months. So last 2024 has been really exciting as far as trauma literature is concerned. And next couple of slides, I'll be sharing what new is happening as far as trauma world, ocular trauma, or I would say ophthalmic trauma, what is happening today. So we had a very interesting discussion in the early part, and we had very nice comments by Dr. Prem about what to do in a NPLI. And there are a lot of good evidences coming in 2024 regarding surgery in an NPLI. There were 2 articles which came in Ophthalmology Retina. There was an editorial actually. And then there was another article which came as an AI model. Can we predict NPL after trauma? So what we know regarding operating the NPLI today, and there has been a very nice article from the Chinese group on guidelines of managing NPLI. And Professor Huayan, he took over this, and it's a very nicely done, and they gave a lot of points. They said that we should, none of the globe is beyond salvage. You must try to salvage the globe, as rightly said, and a decision of vitrectomy should be made. They also went ahead telling that it should be a tailored approach. There are a lot of consideration, patient preferences, psychological consideration, adherence to follow-up, and so on. So this is what today we know about. And last 3 months, there are some new evidences which are coming. So this was from those articles from Ophthalmology Retina. They went ahead giving a numerical number to it that approximately 20% of the eyes with open globe injury, which present with NPL, recover light perception or better following a primary repair and vitrectomy. They also went ahead telling that timing of vitrectomy, if you want to really salvage or get this 20%, you need to operate early vitrectomy, 4 to 14 days. That means definitely before 2 weeks, the vitrectomy should be done. And they said that the scan which was shown in that presentation, the disorganized intraocular contents on B scan ultrasound is a poor visual marker. So if you have these disorganized content, nearly 50% of the cases, the outcome will not be PL or better. So this is one of the things. There's another article, so I have combined those 4 and given some of the information. So VEP, And they said especially the amplitude of signal could be a adjunctive tool for assessing the likelihood of visual recovery. And they said if it is a non-measurable VEP, usually they will end up with a no perception of light or minimum vision. So definitely it adds up to the current knowledge that it's not but if you have disorganized globe, you have non-recordable, non-measurable VEP, these are the cases. Even if you do early vitrectomy, you even do a primary repair as early as possible and early vitrectomy, the outcome may be poor. This was an interesting article by the same group, Huayan group from China. They created an AI model called as a Vision Go AI model. And they fed in a couple of characteristics and then predicted whether he will return back PL or not after surgery. So it had both during vitrectomy parameters and pre-vitrectomy parameters. The AUC was pretty encouraging, 0.75 for predicting visual outcome before vitrectomy and nearly 0.9 during vitrectomy. So that was good. And when I went searching this, it is a freely available AI app which is there in the net. So there are parameters you feed in, and then it will give you what is the chance that the PL will come back. Now, probably it has been done on a large database from Chinese population. I think it is a time that Indian population, we should look whether this works or not. It also came out with some new prognostic markers, which were not told before. One was a total wound length more than 12 millimeter. So if the total wound is more than 12 millimeter, if the distance from limbus to the posterior of the full thickness scleral wound is more than 8 millimeter, they suggested that these are the ones which have got a very poor visual outcome. And they also found some markers for a higher chance of visual recovery. One was after a VR surgery, if you can successfully attach the retina, retinal reattachment, definitely these are the cases, vision chance of improvement is more. And second, they went ahead because many a time, I think Prashant will agree, many of these cases, we do a 360-degree relaxing retinotomy to attach the retina. We leave a small island, and they said that if there is more than 60% of the retinal residue which is remaining, again, they found that these are the ones where visual recovery would be more. So this again giving us that if you want to do a retinotomy, probably do as anterior as possible, remove everything and try to, if you can attach the retina, chances that this NPLI will convert to a perception of light or better would be more. So some good evidences regarding managing NPLI in last few months. There was also some evidence that how long we can safely delay a primary repair in open globe injury. So what currently we know, and this was the article which came in Ophthalmology from Dean Elliott Group, who tried looking at the two things, visual outcome and risk of endophthalmitis. So what is the current standard? Although the current standard is that we repair the open globe injuries within 24 hours from the time of injury, very limited literature is there to support this recommendation. What we have evidence is mainly open globe injury with intraocular foreign bodies. And we all know that each day delay with an intraocular foreign body can increase the chance of endophthalmitis by nearly 4 times. So no, the problem what we have also discussed this earlier in this webinar, that we do an early repair, often the patient condition is suboptimal. And what happens if we delay the primary repair? The visual outcome and endophthalmitis is a big question, and this ophthalmology article tries to answer that. So what they found that while repairing open globe injuries within 24 hours remains the standard of care, this study also found that delaying the repair to 36 hours doesn't increase the risk of endophthalmitis, or it doesn't impact the visual outcome. However, they said that if you repair it beyond 36 hours, definitely there is a significant risk of endophthalmitis. So this study actually suggests that under certain situations, like when you're optimizing the operating conditions or managing hemodynamically unstable patient, it's reasonable to delay the repair more than 24 hours without substantial increase in the risk of poor outcome. So this becomes important. In our country, we try to do it as early as possible, but this evidence in US is important because there it becomes a lot of medical legal thing, and just delaying for one more day will not hamper the visual outcome and the risk of endophthalmitis. Coming to the last part of the newer articles, I thought that there have been some reports now after RO 2024 about can we reduce inflammation by doing better repair. And the group from Johns Hopkins has come out with this nanostructured anti-inflammatory sutures. And they came out with two posters in RO, and that has subsequently come in IOVS as abstract, where they tried looking at these anti-inflammatory sutures are nanostructured particle sutures, which are impregnated with DEXA. And they are dexamethasone eluting sutures. And they went ahead showing the first study where they looked into the animal eyes, the rabbit eyes. They created an alkali burn. They make a cleared corneal incision and tried suturing it. And the right graph shows how opaque the cornea is. And they could significantly show that the opacity, corneal opacity, was less. So this, in principle, showed that probably this suture can be replaced by our routine corneal suturing, what we do. And they went ahead doing a clinical study, trying to see the willingness of use. And they found these are the diameters. And they gave the sutures to the surgeons, 9 surgeons who tried using it, not on a real case, but on the animal eyes. And they found that these dexamethasone eluding sutures are also rated equally good as the polygalactine sutures. And they also found that except for not burying, other things and glidability, which seems to be low with these newer nanostructured thing, the wound strength, the chance of inflammation, corneal opacity, all are low. So probably in next couple of years, we'll be seeing more of these nanostructured sutures, which we'll be using for corneal trauma repair. Thank you very much.
Thank you,
Dr.
Rajiv. I think,
Rajiv, for wonderfully bringing out highlights.
Yeah, it was brilliant because it showed what exciting times we are in for ophthalmic trauma. I think a lot of our assertions about ophthalmic trauma were based on clinical impressions and anecdotal evidence. And it's time now to get a lot more of evidence to back them up. So I think Raman has given us some of those studies, which are quite exciting and herald an era where we will do more work which is evidence-based.
Thank you, sir.
Thank you, Dr. Raman. And we invite Dr. Vipin Rana for his talk on retina. Please.
We can have Dr. Vivek first.
Vivek is, yeah, definitely.
Yeah, Vivek has some commitment. So Vivek and then Dr. Vipin, sorry.
Sir,
Can
Dr.
we have
Sandeep's presentation is also there, so he's ready with his
Yeah. We will have Vivek, and then if you don't mind, please.
Sir.
Vivek has requested. Vivek, can you share your?
Please.
I'm sorry, I was told as a panel, so I'm not sure whether.
Yeah. That's what I was surprised, Prashant. Vivek is on panel. He will be discussing
I'm sorry.
retina cases.
Oh, correct. Oh,
Yes.
sorry.
That's
That's
presentation. Unfortunate.
Vikram Thapa.
Sir, Dr. Sandeep is there for his lens presentation. His presentation is ready. Can we play that, sir? Dr. Sandeep Gupta.
Sir, his presentation, my presentation is with him. Whatever you decide, sir.
First, let us have retina because Vivek has to leave. That's what he's saying.
Perfect, sir. Not an issue at all, sir.
I'll just upload it.
Vikram Thapa is there? Can Dr. Vikram Thapa? I think he's not there. So, Vipin, are you ready with your presentation?
Yes, I'm ready, sir.
Wonderful.
At the outset, I would like to thank, am I audible, sir?
Yeah.
Yes.
Yeah, I would like to thank Ocular Trauma Society and AIOS for giving me this opportunity. So I'll be discussing a patient, 35 years old male patient, who underwent open globe injury repair elsewhere, which was there in the zone 2 and zone 3, and presented to us after 1.5 months, where so this was the presentation. Vision was PL positive and phacodonesis was present. So underwent lensectomy with 25 gauge. And this is a closed, this is a funnel shaped retinal detachment, closed funnel, where this PVR changes you can see. So the PVR membranes, they were peeled. So PVR membranes were they were taken out, dissected with the help of the this faucet. And after that, the PFCL was injected. PFCL acts as a third hand of the surgeon. So we can see the opening up of this funnel after injecting the PFCL. And what we can notice is there was a break which was present in the supranasal quadrant. So we plan to take out the PFCL, and after that, BBG dye was injected. We can inject the BBG dye under the PFCL also, but I intended to inject after taking it out PFCL. And after that, the ILM peeling was done, as it may prevent the future formation of the ERM. The vitreous-based dissection was done 360-degree, and inferiorly, we can see the vitreous hemorrhage which was present. So this vitreous hemorrhage was also cleared. And again, this fluid was aspirated to make this detachment shallow. And what we can see that there was a retinal fold. It was because of the incarceration of the retina in the temporally where there was an injury in the zone 2 and the zone 3. Ideally, I should have put 277 and 240 in all such cases. However, there was a lot of fibrosis because of the repair of open globe injury elsewhere. So I could not put 277 and the 240. And I proceeded with retinectomy. So we can see the retinectomy is done and it relaxes the retina. So PFCL was injected and the fold which was present because of this incarceration is gone now. And we can see the clearly attached retina. So after this, the endolaser was done at the margins of the retinectomy. So this is frequency doubled NDR laser, which I'll be doing. So this is the endolaser, which we can do at the margins. So the laser was done 360-degree in the periphery and also around the break, which was existing break, which was present in the supranasal quadrant. And after that, the endos PI, that is the inferior PI, was done with the help of cutter only. And the PFCL silicone oil exchange was done. We can do the PFCL. This was a direct PFCL silicone oil exchange done. We can do it with PFCL air and then air silicone oil also. So we can do, this is a surgery, this is the eye at the end of the surgery. And on post-op day 1, patient had a visual acuity of 6/24 and well-attached retina. And after 4 months, now patient is having 6/18 vision and the silicone oil is in situ and the retina is well attached. Thank you so much.
Dr. Vivek, Dr. Rajiv.
Yeah, nice surgery. Just couple of points. I think, as you rightly said, these cases, many times you sacrifice the lens. That's fine. Lensectomy is needed. The only thing is where you have done a RR, you want to remove that anterior retina also because there's a lot of vitreous there. Usually, if you want to do a retinotomy, it's always better to do about a 180-degree, no, just a small retinotomy. later on the anterior vitreous can contract. So I would have probably done a little more retinotomy there rather than a very localized one. Otherwise, it's important that you remove all pre-retinal membranes before you inject LPFC, because many times if anything, is because you did try and then again you had to remove the LPFC, then peel. So there definitely, and along with your ILM, there were a lot of some pre-retinal premature membranes would have come out. So I think great job. Ultimately, you did a good job. The patient retina was well attached.
Thank you.
Yeah, I think I would second Dr. Raman's point in relation to being liberal with the retinotomy. And when you see these folds, though this was a very clear fold indicating that possibly it is due to incarceration, but suppose you have a relatively crumpled looking retina somewhere, this large retinotomy would also help you to actually lift the retina up and examine the undersurface. Because this is trauma, PVR is going to be everywhere and one component is likely to be subretinal. It's a good idea if you can have a large one which will help you see the aspect of the retina below. So in case there are any membranes there, you can remove. Again, cannot be emphasized more that the anterior flap should go away. As far as the inferior PI is concerned, I am a big fan of making the PI right away when one enters the eye, from the point of view that sometimes these PIs, when we make, they may bleed. So your course of surgery, that's the next half an hour, 40 minutes, gives you time enough for it actually to, clot off, or for you to raise the pressure and ensure that the bleeding stops, rather than have bleeding right at the end and then sort of struggle with closure. But all in all, yeah, difficult case, and I think very good outcome.
Thank you.
Surendra, shall we proceed with the cornea one or with the lens ones? May I request Dr. Sandeep Gupta to make his presentation then?
Thank you,
and
sir.
Then we are
Sir.
glaucoma.
Thank you, sir. I have a video with voiceover, and I request Dr. Vipin Rana to play the video because my net is a little patchy here, so the video has already been shared with him. So primarily, I'll be dealing with few cases where we had a combined lens and corneal trauma. In cases with combined corneal and lens injury, I thank TCA for this opportunity to talk about traumatic cataract management. In cases with combined corneal and lens injuries, globe integrity is of paramount importance, and cataract surgery is usually delayed unless endothelium is compromised. When a cortical wash is done with corneal repair, and a secondary IL is usually implanted later. And it is better to leave a capsular film so that later on you can put in an IUL. Again, it is preferable to feature corneal bones in children for better integration. Corneal bones should be sited in a way to have a clear access for cataract surgery. As in this case, a temporal incision is preferred as there is a inferior corneal scar, and a superior incision will not be appropriate to finish off surgery. With a temporal incision, we can easily do so. In cases with corneal scars, staining of capsule helps. Also, if needed, make a large centric rhexis, preferably with forceps, again to have a clear field of manipulation. In this surgery also, since there was a central corneal scar, use of forceps allowed us to finish the rhexis. Also, iris was used to manipulate pupil away from corneal scar to have a clear area for completing surgery. In cases where integrity of zonules are in doubt and there are posterior synechiae, they support the capsule well, as in this case. Keep posterior synechiae intact. In fact, in this case, we left the capsular pattern area of weak zonules also and facilitated the opening after IOL implantation for a successful surgery. You can very well see IOL is implanted and then we are facilitated the opening with a microaxis forceps and scissors. This patient has a repaired corneal scleral perforation with a thin limbal area. and zonal dialysis with fibrous capsule. Since he was a young person, the rest of the granules were strong and intact. Point to notice that if we use the needle to capsulotomy at the area of fibrosis, the capsule will tear. So in these areas of fibrosis, we use a microaccess forceps to easily tear out the forceps capsule and make a tear capsulotomy. Also, if we see here with the system is shown, what we are doing is we are deliberately making the capsules eccentric. As once we fixate this bag, the bag will shift with fixation. If we do it with Harrison's also or with CTL. Now, in this case, after doing this cataract, which was eccentric, we were able to successfully complete the cataract. And after this, the bag was stabilized with 2 irisotomes to prevent further damage to the granules during nucleotomy. The location of irisotomes were not ideal. However, it was necessary due to thinned out limbal area at site of previous removal. So, with this irisotomes, we prevented further damage to the granules, and a nucleotomy and cortical removal was done successfully. And bag was now fixated with a CTR. And now we can see that bag has shifted after the CTR implantation. And the capsulotomy has become more central. Once we implant the IOL, we'll see the IOL is also very close. So in conclusion, what we need is meticulous pre-op workup so as to plan our steps in such situations, like when to time the surgery, what steps to be changed, and how to follow. Also, meticulous follow-up, especially in children, is very important to prevent. Thank you so much.
Thank you so much, sir.
Very nice case, very nicely managed. Dr. Vaishali, your quick comments on this.
Yeah, I think this was a brilliant case and all the points were brought out. I think I just want to highlight 3 things. Number one, like you said, and where like was discussed in cornea, the timing. Cataract is never an urgency typically, unless there's floccular material causing inflammation, just remove that. And particularly for the residents or the fellows or trainees, where sometimes in the middle of the night you will see a case and you will be tempted to do that. Please wait. Treat the eye, treat the inflammation, and then do the cataract. The second thing is, this is the case where you want to use all possible instruments and viscoelastics, heavy viscoelastics, bimanual, and delicate instruments like was shown. And I think third thing, put an IOL only when you feel that you are able to put it safely and securely. Something that is tilted or is going to come up, pop up through the pupil, capture up, then you don't put it, wait for 4 to 6 weeks and then do a scleral fixation. So I think these are my 3 points.
Yeah, thank you, Dr. Vaishali. But quick, 1 or 2 things which I would like to say that our iris retractor or capsule retractors should be in the area of maximum zonal dialysis. 1. Secondly, when we are inserting our CTR or Sioni ring, then our capsular bag should be well inflated with the viscoelastic. So otherwise this CTR will pierce through the capsular bag and it will make an opening in the capsular bag and it will go behind in the vitreous cavity. And very nicely done capsular access. This I really appreciate, because the nice circular capsular access is very important. And the use of micro access forceps in such loose capsules is really helpful at times when we can use it from various places. This is what it is, and a single piece lens is good enough. And earlier they used to say that a 3-piece lens is good, but if you put a good CTR. Another thing is we can fixate the capsular bag in this case when the zonal dialysis is more than 3 clock hours, and we can use a CT segment and fixate it to the sclera in the periphery, or maybe you can use a Sioni ring for the better long-term centration of the lens. Thank you, Sandeep.
Thank you, sir.
Thank you.
Thank you, sir.
Dr. Rajoria, Dr. Rajoria, Dr. Vedant Rajoria.
Yes, sir.
So please upload your presentation.
Yeah, good evening, everyone. Today's talk is on unlocking the unknown approaches to the management of neglected traumatic cataracts. So first, let us understand what is traumatic neglected cataract. These are the cataracts occurring due to the ocular trauma, which are left untreated for an extended period, typically more than 6 months. Primary purpose of this presentation is to address the challenges associated with these neglected traumatic cataracts, which includes chronic inflammation leading to syncytia formation, thick fibrotic membrane formation, secondary glaucoma, macular edema, and macular hole, which will further lead to surgical difficulties. So how do we plan to approach these surgical difficulties? This will depend on morphology and presentation of these traumatic neglected cataracts. There is no single definitive approach for operating such cases. Instead, we need to employ various permutation and combination of these enlisted methods to effectively address these challenges. Now, let us open the Pandora box and see different approaches to manage neglected traumatic cataracts. This patient presented to us after 15 years of ocular trauma. We approached this case with Cyclodialysis with 26 gauge needle and iris depositor. Followed by an insertion of 3-piece IOL in sulcus and membranectomy from pars plana route to clear visual access. Another case with intact capsule, so we approach this case by capsular access with 26 gauge needle and microrhexis forceps. Lens matter aspiration is generally avoided as cortex is adherent to the capsule, and this increases the risk of zonular dehiscence. So a gentle hydrodissection is done and removal of the lens matter as a whole is done via tunnel. Followed by remnant membrane removal with Vanna scissors, cortical cleanup, and insertion of single piece foldable IOL in the bag. This is the third case showing neglected traumatic cataract in pediatric patient with totally calcified lens matter adherent to the lens capsule, which was approached with Cyclodialysis, anterior lens capsule rupture with 26 gauge, and removal of lens matter with vitrector, followed by a rigid PMMA IOL insertion in the bag. Another case with a similar approach. Take-home message for all of us is prevention is always better than cure. So patient education has the utmost importance. So prioritize patient education and thorough counseling. Emphasis on early intervention as well as early presentation. Visual rehabilitation by implementing comprehensive post-op management to address amblyopia. Lastly, to encourage ongoing research and innovation to improve strategies. Thank you.
Please, Dr. Vaishali, for your comments.
So again, I think you brought out a very valuable point that one, just because it was neglected or it is a delayed presentation, don't give up on the patient or don't give up on the eye. Yes, the child may be amblyopic, but provided you always do a B scan and rule out any retinal coexisting detachment or funnel shaped changes before you do that. But always try, don't give up. And even if it is a delayed case, do your best. Of course, it will depend from case to case, but I think two very important points that I wanted to highlight. If you are contemplating a membranectomy or a pars plana entry, make that before you make any wound in the or entry in the eye, because it's very, very difficult to get that trocar into the eye after your eye is open. So I think that is one thing I wanted to highlight. The other thing is the use of preservative-free triamcinolone acetonide, because we must make sure that we have done a thorough vitrectomy. And even at the end of surgery, this should be injected as an anti-inflammatory, but also as a diagnostic to pick up any residual vitreous. And like, again, same thing, that IOL should be placed only when you are confident enough of its proper placement. Otherwise, wait and do a intrascleral or a sutured scleral fixation.
Thank you. May I request Dr. Shikha Gupta for her presentation to upload her presentation? Thank you, Dr. Vedant.
Thank you, sir.
Dr. Shikha.
And thank you, the glaucoma, for your patient aid.
Dr. Devendali, are you there? And
yes, sir, I'm there, sir. But if Shikha is not there, why can't Preeti present first?
Yeah, Preeti, if Shikha, Preeti, please upload your presentation.
I'll start sharing.
She's anyway a extraordinary presenter.
Oh my, thank you, Dr. Tully. And without much ado, I start. My presentation is visible?
Yeah, yes.
Sorry.
No, it's fine. Go ahead.
No, I'm not able to see my presentation yet. I think others are able to. Are you able to see the presentation?
Yes,
of
we
course.
are.
Okay, all right, fine. So,
Why don't you go to the next slide? Maybe you can see it.
yes. So, trauma and glaucoma, one single case. So, it was a 15-year-old boy. He presented to us on 16/4/2021. And the history of trauma, accidental trauma with a friend's hand in February, on February 17th. So basically 6 weeks later, and immediately there was loss of vision. From his charts, we could make out that he had full chamber hyphema. The primary ophthalmologist gave an AC wash, and always the intraocular pressure was between 20 and 28. But however, the record showed that it was always on NCT, never on applanation. There was no mention of disc status on the records. And when he came to us, he was on treatment with acetazolamide, prednisolone, dorzolamide, and brimonidine timolol combination. And what were our findings? So his right eye vision was 6/5. The left eye, that's the injured eye, 6/151. Right eye was normal in all respects. Left eye cornea was clear. The pupil showed traumatic mydriasis, 360 degrees angle recession, PSC, and the disc showed advanced glaucomatous damage. And this is what the discs were. Right eye was fine. Left eye, it's a hazy disc, but you can see it's an advanced glaucomatous damage because of the cataract. It's not very clear. And what were the fields? The fields were tubular. So this is the 24-2, this is the 10-2. Right eye was normal. So I would say in a summary, it was a 15-year-old boy who suffered ocular trauma. He had medical intention immediately. He didn't neglect it. Acute phase probably was managed well with the AC wash. But however, under medical supervision, he goes from normal vision to tubular vision in 6 weeks. Now that is something which should not occur ever. And if we just take a pause, what was the problem? I mean, the intraocular pressure in a closed globe injury should be taken only with applanation. Maybe there is coexisting corneal defect in the early cases. That is when you may be excused. But an NCT will typically underestimate the pressure. And you may think that pressure is only between 20 and 28. Oh, I have time. Second is monitor the disc. The disc will show changes and prostaglandin analogs were not given. Prostaglandin analogs are not contraindicated even in acute trauma. The inflammation, whatever is there, can be taken care of with steroids, and PG analogs should be started. Step-by-step approach of adding medical treatment need not be followed in neovascular glaucoma or traumatic glaucomas. So this is, and the field should be done as early as possible. So this is what, as a primary ophthalmologist, that is what needs to be kept in mind. And this is what was missing. So how did we proceed is, of course, I added PG analogs and netazoidil attacked but however, the pressure did not budge. Then I knew I had to intervene surgically. So it was whether I should do a TRAB, whether I should do an AGV, or should I do a cataract plus TRAB or a cataract plus AGV together, because he had a visually significant cataract. However, looking at the advanced field effect, it was decided that the IOP needs monitoring first, control first, and the cataract can wait. So, and of course, with adequate counseling, what we did was, I did a trabeculectomy with MMC, which failed in 1 month. A needling, which worked only for 7 days, and the pressure was back to 30 and 35. And that's why just after a month of the trabeculectomy, I did an AGV, and it worked, and the pressures were between 14 and 18. And cataract, after cataract with IOL implantation was done about 4 months later, and the IOP was maintained between 13 and 16 without any medical management. So he got this at least a temporary vision after cataract was 6/9. The tube is well placed. The disc will remain what it is. The fields have not worsened. So this is not a permanent happy ending because he will require lifelong monitoring. But however, what we can conclude from this case is not to show trabeculectomy in a traumatic case. It's not to show AGV. It is to show that under medical supervision, a person cannot go from 6/6 vision or a full field vision to tubular vision just because we didn't follow certain principles, and that is intraocular pressure only with applanation. Early cases, if the cornea is damaged, maybe you can use another modality. This damage can be very fast. Fields should be done as early as possible. Prostaglandin analogs are not contraindicated. Step-by-step approach does not have to be followed. Trabeculectomy can fail very fast, and particularly in young patients. AGV you can use as the first line of treatment, and lifelong monitoring has to be counseled of intraocular pressure and for retinal examination both. So thank you very much for the opportunity given, and I will stop my screen sharing.
So Mayuri ma'am, Dr. Kamar ma'am can comment.
Preeti, it was an excellent presentation and management. Only 2-3 points I will make here. First, never leave your patient of a high FEMA unobserved. Up to 3 months, you have to closely monitor, because once you have done the paracentesis, the pressure may go down. But because of the angle recession, the gonioscopy was not done before. So because of the angle recession, the glaucoma can happen during the lifetime. So close monitoring is required. If you have a corneal epithelial defect, applanation may not be possible, but you can use eye care in that case. So it's a good tool for the traumatic issues. Thirdly, counseling is very important. Maybe you have advised patient to come, but repeatedly counseling has to be done for the lifetime follow-up. And documentation of the disc is always mandatory. So repeated documentation will tell you that how much deterioration is there. Secondly, sometimes we miss this steroid-induced glaucoma in these cases. Heavy dose of steroids are given to all traumatic cases. So it is possible that steroid might cause the glaucoma. The trabeculectomy in your case, why it has not worked, it's a question. But I will not use mitomycin in the early case of trauma. Because in early case of trauma, usually that IOP rise is temporary for some time. So when we use mitomycin, it should be used with the caution, because it might lead hypotony in the later. So this is all I would like to, but counseling and counseling. Even a child is young, I always tell him that your parents may not be there to tell you, but you have to have regular examination with the ophthalmologist.
Dr. Murali,
thank you.
Your comments.
Yeah, thank you. I think it's a well-managed patient, but the surprise here is that such a short period of time, the intraocular pressure has been probably left unmonitored. The pressure has gone up and damaged the optic nerve so significantly. I think the point I'd like to reiterate here is the close IOP management and follow-up with regards to trauma and following up, and even after the AC wash and so on. And I'm also a bit surprised about the failure of the trabeculectomy. And I would use a very, very low dose mitomycin
in such cases, and if at all use mitomycin. And then a trabeclectomy generally does work. I'm surprised that it didn't work. So in such a short time, it had to go back and you had to put in a tube. And I would hesitate to put in a tube in very young children, especially when the trauma and the glaucoma is not going to progress very much. I would probably try needling and medication and give other options a chance before I would go and put in a tube. I think, but overall, I think it has been managed well. The only problem here, the lessons to be learned and picked up here is the close monitoring as far as IOP is concerned following trauma and hypema, and the need to do trabeclectomy, and always get a second opinion with regards to glaucoma management when there's such a difficult case in a young patient. I think get a second opinion with regards to the extent of damage, the amount of the angle recession, and also the options for management, especially surgery in these kind of children.
Yeah, can we have last batsman, Dr. Shika? We are really sorry for
so that's okay. I hope everybody has energy left for this presentation, so I'll not take much time. Thank you for the opportunity. So I'll be talking about traumatic cyclodialysis. So are my slides visible?
Yeah.
Okay. So the situation is tricky, but we have a way out. We've got a plan how to deal with it. So I would say that traumatic cyclodialysis, we should not waste time much in conservative management. Usually they are large and do not heal with conservative management. So we go for, there are two options. So conventionally, cyclopexy, that is suture-aided correction, has been advocated. But these days, we are going for the cyclotamponade. That is, we're tamponading either with an external agent outside the sclera or with an internal agent. We'll be coming through the different gamut of cases that I'll be presenting. So sometimes it looks like the cyclodialysis is small, but we have described dynamic gonioscopy, where the patient looks towards the mirror of the gonioscope. And then we actually find out the latent extent of the cleft. Similarly, the same technique can be used on UBM, where we see when the patient looks towards the side of the cleft, the extent increases, and therefore we should be knowing what we are dealing with. We've also described that instead of UBM, we can use swept source OCT. For example, in this case, it shows clearly a bizonal cleft, which can be missed sometimes in a UBM, as we can see a small here and a large cleft here. And here also on UBM swept source OCT, we can see that a dark area is visible, which is actually a cleft. So external cyclopexy is a blind procedure. We have to open up the sclera, cut down, and pass the sutures through the uveal tissue, the cyclodialysis cleft, which sometimes misses the exact location, and the procedure itself is fraught with a lot of complications. And therefore, what is being advocated these days is internal endocyclotamponade, where a multi-piece IOL or a Cioni ring is basically placed in the sulcus, and the diameter of the haptics of the PCIOL or a Cioni ring is such that it gets compressed when it's placed in the ciliary sulcus, thus causing endotamponade of the detached ciliary body. So we have also applied use of two endotamponading agents. For example, in this case, which is a refractory case of cyclodialysis, presenting for more than 1 year, failed external cyclopexy elsewhere, and we can see a huge amount of cyclodialysis here. We put both a multi-piece IOL and a Cioni ring in the sulcus, and it helps close the cyclodialysis cleft in a good way. This was a case, very interesting case, which presented to us. It had, actually, these cases are traumatic cases, so they have multiple weeks of dialysis. So this was an adult dialysis along with a cyclodialysis. So UBM also showed the exact presentation of the cyclodialysis. So what we did in this case was we passed a single suture through both the iris as well as the cyclodialysis ring. So this is the photographic depiction. So the suture was passed through the iris root, and also this was the polypropylene needle which was passed through the Cioni ring, was then passed through this. So as the Cioni rings was slided into the sulcus, the iris also was got appositioned, and this was the post-operative picture where the iris root was apposed, as well as the cyclodialysis cleft was closed because of the endotamponade action of the Cioni ring in the sulcus. So this was pre-operative, and we can see post-operatively both the rings are closed. So this was a single suture closure for both the rings in this case. Another interesting case came to us where there was 3 rings which was dialysis. So there was a zonular dialysis, there was a cyclodialysis, and there was a iridodialysis in this case. So we managed the zonular dialysis by placement of a multi-piece IOL and a CTR in the bag. The cyclodialysis was managed by putting Cioni ring in the sulcus, suture to the area where there was maximum cleft, and iris dialysis repair was done with a stroking drop technique we described previously. However, post-operatively, we were met with a surprise as the cleft did not close. We found that because of zonular dialysis, the Cioni ring that we had placed in the sulcus actually slided down and was not opposed to the ciliary sulcus. So we came to the conclusion that the cyclodialysis repaired with the endotamponade of the Cioni rings do not work if there is a zonular dialysis or a non-intact bag. So then we went on for this patient to invent a single suture, single knot ab interno cyclopexy, which was we called as modified swing machine technique for the repair of cyclodialysis. So this is the video. So this was the case where the triple dialysis ring had failed. So we made the scleral groove, partial thickness scleral groove in the location where there was the maximum cyclodialysis cleft. And in a 26 gauge needle, we sutured the proline suture, a 90 proline suture, and passed the suture consecutively, passing through the ciliary ring, which was detached here, so that it opposed to the sclera and caused closure of the cyclodialysis cleft here. So multiple knots were taken out through this, and the last knot, which was taken out through the same wound, was then threaded through each of these the knots, and we had a single suture which was closed here, and zipper closure of the cyclodialysis cleft was achieved. So this was the post-operative appearance. You can see on UBM pre-operative, there was a large cleft which got sealed, and the patient has achieved good visual acuity hence. So at the time of this presentation was made, we had done 7 cases, but now more than 20 cases have been done. So we usually preferred modified swing machine technique when we have the contraindications like dialysis, of zonular dialysis or PCR. But the cases have really done well, and then we have gone on to present our technique of repair. So usually we go for internal cyclotamponade with the cyclodialysis with the CTR ring, because it heals the entire circumference of the cyclodialysis, and concurrent injuries can also be dealt with. However, swing machine endocyclopexy, it acts by acting inside out, and hence it is 100% sure, and it is safe, easy, and effective for repairing both primary as well as recalcitrant cyclodialysis clefts. Thank you so much for giving me this opportunity.
Thank you, Dr. Shekhar. That was an excellent presentation. An area which is less charted. Let's have Dr. Devantuli comment on this, please.
Yeah, thank you, sir. I think it's very important what Shikha has brought out, that cyclodialysis is not as uncommon as we think, and it's a difficult proposition to pick up for a general ophthalmologist. So in that case, I think gonioscopy is good, but ancillary tools like UBM and others which are available at RP Center may not be available with everyone. So I think gonioscopy, a well-done gonioscopy, can pick up cyclodialysis very well. I've heard Shikha before. I think she's one of the leaders in India for bringing out various techniques for cyclodialysis repair. So I think, Shikha, this is one of your masterful presentations. Very well done.
Thank you, sir.
Dr. Murli, do you have something to add, please?
Yeah, I think excellent presentation by Shikha, and I think as usual. And I think the points to highlight here is the meticulous attention to detail, in the sense that you have to see the angle, you have to see whatever else test which you have in terms of swept source, OCT, or any other technology that you have, and employ the techniques to deal with the iris, to deal with the angle, and to deal with the cyclodialysis, and monitor the intraocular pressure. Suppose everything else has been done to your satisfaction, but still the IOP does not respond, the IOP remains low. You must know that something is still not working, and go back and review the cyclodialysis, area of cyclodialysis, and see if that can be sealed in some other method. The key is to persist and go back and review everything, and not just to do what you think is right and leave it alone. And lastly, I think what Devantuli also mentioned, that these are all complex cases and needs investigation, management, and reviews by a good team who has experience in dealing with these things. It's not for everyone to deal with cyclodialysis in the way she has described.
Yeah, very apt. Dr. Mayuri? I think Mayuri
The same as what Murli has said, this is not a cup of tea for everyone.
That's what glaucoma
I also agree
for.
with Murli that it
Your voice is breaking, Mayuri.
is it?
Now,
Am I?
better now.
I will not advise everyone to take up such cases.
True.
Sorry, sir.
It's better now.
So the advice only is always investigate these patients properly. Okay. And
Your voice is breaking. So
don't try to do it yourself. Always, it should be a team approach, and pressure monitoring is must. That is what I say. It is not a cup of tea for everyone.
thank you. I think what we've had was the first case which gave some very good carry home points to a general ophthalmologist. And the second case was, or second case series was really for us to understand, that there are problems which need to be dealt by the super specialist with the experience in handling those conditions and the equipment and the investigative tools to manage them. So I think that the points were very valuable, and we would all have learned a great deal from this webinar. I would like to thank the OTSI team, which has put together this program along with Prashant, and I will hand over to Prashant to say the last word. But one word before that, requesting all of you with so much wealth of experience in Ocular Trauma Society of India, Ophthalmic Trauma, where we are learning a great deal more now. And I think we can take it much further with the efforts of all the specialists that have joined in today. Hand over to Prashant for the last word.
Thank you, Dr. Grover, sir. It was wonderful webinar, all courtesy, and I should thank sincerely Dr. Mehul Shah, whom we are seriously missing today. He was the brainchild behind all this drafting and getting all the pool of speakers and wonderfully drafting the topics for them as well. So it was all in all a very comprehensive webinar, and the intention of it was that it should send some certain messages to the comprehensive ophthalmologists practicing in the periphery with the minimal of the setup. And really, today's webinar turned out to be almost 90% of it. We could send out some good messages. Even the Saransh, way Dr. Rajiv Raman has put across the ideas and what is happening new, also was very well put across. So without much ado, we are all quite late for today's webinar. So I would take this opportunity to thank President of OTSI, Dr. Grover Sir, Mehul, Dr. Purendra Bhai, for last minute chipping in and coming and taking over the whole job of moderator and the whole OTSI team of ours, as well as all my sincere most thanks to all the speakers and the expert panels who have made this discussion so lively and interactive as well as educative. So, sir, with your permission, shall I call it a day?
With apologies for having delayed people for their dinner.
Yes, sir. Yes, sir.
Thank you, sir. Thank you all.
Thank you, everyone. Good night.
It was wonderful.
Good night, everybody.
Grover, sir.
Nice discussion.
Bye.
Thank you.
Prashant, sir. Thank you so much.
Thank you all.
Thank you.
Thank you so much.